Thank you for coming. Welcome to the 2024 Chagas Hub World Chagas Disease Day Symposium. It's a bit of a mouthful. The event is being recorded, and so please just bear that in mind when you're asking questions at the end of each session. My name is David Moore. I'm one of the infectious disease consultants up at the Hospital for Tropical Diseases and also work here at the school. And each of the speakers during the afternoon will introduce themselves. Let's make a quick start. Some housekeeping. We're not expecting any fire alarm tests, and those of you familiar with the building will not be familiar with the current layout of the building. If the fire alarm does go off, there are several of us who are aware of the way to go, but essentially it's that way, and we're going out through the rear courtyard. We haven't got a coffee break as such in the middle of the afternoon, although the tea and coffee is there. Please help yourself, get up, join the talks and help yourself. It's all very informal this afternoon. But we will stop for 10 minutes at 4 o'clock for a comfort break if people want to get up, stretch their legs, use the toilets. The toilets are around the corner, and you will need a pass to get out of the toilet. You'll get in without a pass, but you'll have trouble getting out without a pass. So just ask someone for one. And then when we're done, there'll be a a reception upstairs in the foyer with some nibbles and some drinks. If you could turn your mobile phones to mute, that would be helpful, just so that we don't record your ringtone. And because the session's been recorded, we have got some microphones, so when you're asking questions at the end of each talk, if you have any questions, then if you could just wait for the microphone, then those will be recorded for posterity. Okay, that's the housekeeping done. As I say, the programme looks like this, and there are 3 copies of it sort of wandering around, so if you want a copy to refer to, then please just take a photograph of it. I'm going to start off in a couple of minutes just talking about some of our outpatient experience up the road at the Hospital for Tropical Diseases. After that, we'll have a short roundtable discussion about some of the challenges we've been experiencing in the UK with regard to testing in antenatal clinics. And we've got Hayley from UCLH, who's been very helpful in that regard. We've got Christina here, who was one of the first members of the Chagas Hub 7 or 8 years ago now, who's come back to talk with us, and Geraldine will talk from the St Thomas's point of view. Then I'm delighted to say we've got Paul, who's come from Barcelona. He's the first author on the multi-bends trial, which you would have read recently, and he's going to give us an update on Chagas trials, and it'll be interesting to hear some of his perspectives on how difficult these trials can be to run. Then we'll have the comfort break. Peter Chiodini, who is familiar to all of you, Professor Chiodini, will talk about managing laboratory incidents with T. cruzi contamination. Then Martin will speak to us about mice and what mice will tell us about T. cruzi vaccines. And we'll finish with Natalie telling us about some time she spent recently in Cochabamba and how that's modified some of her perspectives on disease. So I'm going to move quickly on. It's lovely to see so many familiar faces. This is really nice. Okay, so I'm going to start with a video. This is a video that came from PAHO, actually it came from the coalition, the Chagas Coalition, and really is about the World Chagas Disease Day motto, I suppose. It's in Spanish.
Soy testigo. Eu sou testemunha. Soy testigo. Soy testigo. Soy testigo. Sin embargo, 7 millones de personas han contraído la infección y la mayoría no tienen acceso a diagnóstico y tratamiento. Muchos millones más están en riesgo en América Latina, donde habitan insectos que la transmiten, y en el resto del mundo debido a los movimientos de la población.
Quien ha contraído Chagas por cualquiera de las diferentes vías de transmisión
corre el riesgo de desarrollar patologías crónicas
que se pueden evitar o controlar con una atención temprana,
integral y continuada.
Millones de personas pueden mejorar su calidad de vida, pero escuchen. Pero escuchen. Este es el silencio que acompaña la enfermedad, pero podemos romperlo con tu voz desde las comunidades afectadas, con tu voz desde la comunidad científica,
con tu voz desde el sector político y financiero,
con tu voz desde los sistemas de salud,
com a vossa voz da sociedade civil.
Comparte tu voz con este mensaje para contribuir
a eliminar el Chagas como un problema de salud pública. Las personas con Chagas necesitamos una atención temprana y que se nos atienda de por vida.
Okay, so I'm sorry that was in Spanish and I didn't translate it. I think you will have got the gist that the premise really of this year's theme is about early detection and lifelong management and breaking the silence around Chagas disease. The silence due to stigma, but also the silence in terms of the epidemiological distribution of this disease, which we still don't really have a particularly good handle on to a high enough granularity. And the motto, if you like, that's come forward from the patients themselves, from the federations of patients, is early diagnosis and lifelong care, which means whether we give people antiparasitic treatment or not, they need to be looked after for life. Now, if we had a test, of course, that proved that they were at low or zero risk of progression from an indeterminate phase, then lifelong care wouldn't be necessary, but we're miles away from such a test at the moment. So I want to tell you just a few stories of some of our patients that we see at the Hospital for Tropical Diseases, some of whom have found their way to us directly, some of whom have come from community-based screening events, and some of whom have come from colleagues in other hospitals for temporary management. I'm going to cover a number of different scenarios. All the names are different to their real names, but let me tell you first about Alfonso. Alfonso's a 44-year-old man, and probably like most people, he will have acquired his infection decades before we met him. He was raised in the town of Cochabamba, which I'll show you a map of in a moment, but is in a triangle where many of our patients seem to herald from. And he clearly describes his childhood in a humble home with bricks made of adobe, made of mud and straw, and lots of triatomine bugs in the home at night. He's had quite a cosmopolitan life. He's also lived in Buenos Aires and in Sevilla. He had an episode of dizziness when he was back in Bolivia, and that prompted someone to do a test. So he was diagnosed actually at the age of 39, so 5 years before we met him, because of a potential cardiac presentation. Now, it turned out his dizziness was nothing to do with his heart, but that's nevertheless the reason he got tested. He came to our clinic. He had confirmatory serology, both the ELISA and the alpha test were positive, and he had a PCR test done at that stage which was negative. And all of our PCRs from the Hospital for Tropical Diseases are done by Debbie Nolder in her lab here at the school. Like all of our patients, he had baseline HIV testing, which was negative, and also strongyloides serology, because actually it's relatively common in this population to still have strongyloides years after emigrating from Latin America. And importantly, he's asymptomatic at the time we see him. So, just to orientate everybody, obviously we're talking about people who've come from this part of the world this afternoon, and this is Bolivia, and within Bolivia, this is Cochabamba, where he's from, this is Santa Cruz, this is Sucre, you'll hear about Potosi a little bit later on, but this triangle, this sort of area in central Bolivia, really is, firstly it's a hotspot within Bolivia for Chagas, but it's also a region from which many of our patients originate. So Alfonso then goes on to go through the usual screening that we would do. So he has an echocardiogram, which is normal. He has a 5-day Holter monitor, monitoring his cardiac rhythm for 5 days using one of these rather natty Zeo patches, which is a really convenient way to capture quite a lot of cardiac electrical activity. And those are both normal. So he has indeterminate Chagas disease, no evidence of end organ damage. His parasite DNA is undetectable in his blood, and he was probably infected over 25 years ago. So at this stage we ask ourselves 3 questions. Does he need antiparasitic treatment? Does he need a cardiological review? And once we've done those things, can we just discharge him or should we follow him up? And I think you've probably already realised from the start of this talk that we should be following these people up for life now, which is a change in practice in recent years. So this was his baseline screen. This is what we do for most people these days. And we offer patients increasingly the chance to take antiparasitic treatment, regardless of their baseline PCR status. By and large, that's a change in practice. It's something we were a bit more reticent about in the past, but these days we're offering treatment to many more people. And after that first visit, he will then be seen on an annual basis, where he'll have a clinical assessment to assess whether or not he's developed any changing symptoms, any new symptoms suggestive of gastrointestinal or cardiac involvement. He'll have annual blood taken for T-Cruzi DNA PCR, an ECG to see if his cardiac conduction has changed in any way, and a proBNP just to see whether or not there's any evidence of cardiac strain that is not clinically apparent. And every 5 years we'll repeat his echo, and increasingly every 5 years we're starting to do 5-day Holter monitoring as well. And Alfonso is in good company. A lot of our patients are Alfonsos. They have seropositivity, they're PCR negative, they have indeterminate disease, they're otherwise well. We give them some treatment and then we see them every year. We also see a lot of Albertos. Let me introduce you to Alberto. He's from a similar part of Bolivia. And the only difference between Alfonso and Alberto is Alfonso is PCR positive at baseline. And almost all of our patients who are PCR positive at baseline, who are treated with bentonidazole and ifurtimox, will convert to PCR negativity in peripheral blood. By and large, that is a durable response. We've seen very few people who relapse to PCR positivity after they've converted, but we've seen a few. And we see lots of Albertos, and about 20% of our patients who are indeterminate disease are PCR positive. And when we started seeing this, I was really astonished. Think about people like Alfonso, well, not Alfonso, Alberto, wandering around for 25 years with viable parasites, no end-organ disease, and detectable parasite DNA in his blood for 25 years. I just find the whole concept of that astonishing. And completely well, and not showing any signs of going on to develop cardiac disease at this point. So those are two presentations that actually probably predominate in our clinic. How long we give treatment for is going to be much more the subject of Paul's talk, and I'm not going to second guess what he's going to say. But it is important that we just clarify with our patients what we're trying to achieve with treatment. We know that antiparasitic treatment will reduce parasitic burden because we have this PCR conversion. It's almost universal. But the evidence, as many of you will know, that this then translates into clinical benefit is a bit more tenuous. And that's in large part because doing a cohort trial, a cohort study of patients with these rare outcomes over many decades is almost impossible to do. But the observational data suggests that if you clear parasites, at least change the PCR from positive to negative, that may well change the natural history of disease. But we have to be very honest with the patients. We can't say hand on heart, no pun intended, that we're definitely going to stop them going on to develop clinical disease in the future. One of the reasons that we have quite a large proportion of our clinic are people who've got indeterminate disease and are symptom-free is the work of the Chagas Hub, led in large part by Natalie and others, doing screening in the community. This is going out, sensitising the communities, largely of Bolivians, but not uniquely of Bolivians, in London, that we are offering point-of-care testing. And this point-of-care testing has been transformative in our ability to deliver this screening. And many people come forward for testing. These are the point-of-care tests, one of the ones we used. Let me tell you about Manuela. So Manuela came to one of our screening events. She was also from Cochabamba, but quite unusually, she'd never seen a triatamine. So she'd not lived in the rural areas outside Cochabamba, and she described her upbringing as relatively, really quite conservative, and her parents weren't very keen on her going out and playing outside, let alone going out into the countryside. And yet she came to our event because she knew other people in Cochabamba who had infection, and was really surprised to find that she was positive. She came to the hospital, we did the confirmatory serology, there was no question that she was positive. I think this is going to be a reception. Hello? Yeah? Yeah, someone's coming up, Thanks. Bye. So there we go. Confirmatory serology, she was PCR negative. But it was curious to us, and so you sort of start delving a bit deeper into her story. And this is her family tree, if you like. She's the 7th of 8 siblings. She's the only one who's infected, and she knows that her mother is negative as well. So she hasn't acquired it from her mother. And this is quite an unusual tree to see. Ordinarily what we'd expect to see where there are 8 siblings is that the older siblings may be infected, and then as the family over the years had acquired slightly more an economic status which enabled them to move into slightly better accommodation, the younger siblings tend to be spared. So the pattern we would expect to see is the younger siblings infected and the older siblings not. What happened with Manuela was she was knocked down by a car in Cochabamba when she was 12 years old, and she had a blood transfusion. And this was at a time before blood was being well screened in Bolivia, in this part of Bolivia, and so that's where she acquired her infection. So unusually in her case, she can give us the date, probably, that she acquired infection. Now there are a number of people who left a region at a certain date, and we can say you were infected before this time point, but it's quite unusual and maybe quite useful to be able to know the date at which she acquired infection. The other thing to take from this figure is that Manuela has 5 children. So she's had 5 children not knowing that she was infected, so she wouldn't have proposed that she should be tested. The second of those children was tested and was negative. The other 4 children were still awaiting testing. So let's talk about testing children, because this is an opportunity for us to screen people who have been exposed without realising they've been exposed. Let me tell you the story about these 2 people who came from Santa Cruz, so nearby to Cochabamba, and moved to the UK in 2004. They came to our screening event. To their surprise, they were both positive. Mum then contacted her siblings back in Bolivia, and 2 of them were tested, and they were also positive. Interestingly here, you'll see that siblings 3 and 4 were not positive. Mum was PCR positive, Dad was PCR negative. Both received 14 days of bentonidazole. Mum PCR converted with that 14-day course. But when they moved in 2004, they decided to have a family. So they started having children, and they've now had 2 children. And so we offered testing to the 2 children because the mother could have transmitted it to those 2 children. And indeed, this is a project that Anna, in the audience, I'm sure I saw Anna earlier, there she is, ran as a quality improvement project through the Hospital for Tropical Diseases, tracing and arranging for the testing of the younger children of our patients. And the reason that we had to do this is actually quite a difficult test for primary care to request. And it should be an easy tick box, but unfortunately it's proving very hard for us to get T-Cruzi serology on the electronic tick box that allows GPs to do this requesting. So as this quality improvement project, Anna arranged for testing of 20 to 30 individuals, and this 15-year-old girl, who's symptom-free, was found to be positive and has been engaged in care now. I guess the thing to mention is that she acquired her infection, like everybody else, in her country of origin, but her country of origin is the UK. She acquired her infection here. And she was born at a London teaching hospital with congenital Chagas, which went unnoticed. And there must be lots of people like her. And this is what is sort of leading into the next session, is how do we interrupt this and stop this happening? Screening pregnant women is recommended by WHO, not because you can prevent transmission in the pregnancy you're screening, but because you can then do follow-up of newborns to see if treatment is needed, if transmission has occurred, which it will occur in anything from 2 to 8 to 10% of pregnancies. So you can follow up the newborns and treat them. If you identify a woman in pregnancy, you can then test their other children, and once they've completed their breastfeeding of that child, they can be treated themselves to protect future pregnancies. And more importantly, in our setting, you only need to do this once. Once you've had a negative test, you're not going to get exposed again in a UK setting. So this is a one-off test. And I'll just describe to you Mariana, who is a lady who's currently going through this process. So I said here it's a team game, because this is a surprisingly complicated thing to try and organise, to get infectious diseases doctors to talk to obstetricians, to talk to midwives, to talk to paediatricians with an interest in neonatology. It shouldn't be hard, but it just always seems much more complicated than you might imagine. But Mariana's, again, from the same part of Bolivia. She followed a route that many of our Chagas patients followed, which is they moved from Latin America to Spain and then subsequently moved on from Spain to the UK. And when trying to donate blood as part of the screening, she was diagnosed in 2016. 2 years earlier, she'd given birth to an infant who was healthy, but at that time had not been tested. But she's referred to us because she's pregnant. She's not previously received antiparasitic treatment. So we can't really do much for her during this pregnancy, but what we can do is ensure that her neonate, baby, an infant, has testing, and our current strategy for doing this is a sort of amalgamation of lots of different recommendations, but essentially we do testing of the infant at birth, and then at 1 month, 3 months and 10 months. That's the target, really. And at all time points we're trying to do a PCR test, so we want to see if we can detect parasite DNA, and if we ever detect parasite DNA in any of those samples and we're confident that it's parasite in the baby, then we would offer treatment. And serological testing out at 10 months after we're reasonably confident that the maternal antibody that's crossed the placenta will be long gone. So in the case of Mariana's baby, she was born as a normal vaginal delivery at term in June last year, had a negative PCR at delivery. They didn't turn up for the 1 month follow-up, but they did turn up for the 3 month follow-up, had a negative PCR there, and are just awaiting, it's this month actually, they should have their final PCR and serology. And if those are negative, then that baby has escaped an infection and no further action is needed. And once Mariana's finished breastfeeding, she'll then be offered antiparasitic treatment to protect any future pregnancies. In addition, her older child, that was born in 2014, needs to be traced and offered testing. A brief note about HIV. We're interested in HIV because the consequences of HIV co-infection can be catastrophic, and the image in the bottom right-hand corner of that slide is of neurological involvement with Chagas in a patient with HIV. This isn't a picture that we see in patients who don't have HIV. It's something that's only seen in patients with HIV. And it really looks like toxoplasmosis. It's ring-enhancing lesions. So it's an important thing to try and avert. And we have actually a very small population of HIV patients in our clinic. You can count them on certainly no more than 2 hands, probably only 1 hand. And in addition, and there are studies underway looking at this, where we've looked in HIV clinics, and as you probably are aware, HIV clinics are very well organised in terms of getting testing done. Actually, the proportion of Latin American patients with HIV in London who turned out to be seropositive is very, very low. So it does appear that the demography of patients with HIV from Latin America and patients with T. cruzi from Latin America, at least in London, don't have much overlap, which is, I suppose, reassuring. And there is an ongoing systematic review led by Natalie and led by Jess, trying to work out what the literature tells us, both about the epidemiology but also about the clinical features of HIV co-infection in Chagas disease. Who knows, that might be submitted for publication this year. I'm just going to finish with just to explain that not everybody is well and just treated because of their blood tests. We do see some end organ disease, but not nearly as much as would be seen in high burden countries, and partly that's because we're screening people who are otherwise generally well, rather than screening in reaction to people presenting with cardiac presentations. But this is a lady who was born in Potosi in Bolivia, and those of you who know your history, this is the Silver Mountain of Potosi, which practically bankrolled the Spanish colonialism of the Spanish Empire, really. Potosi is very famous as sort of the most wealthy part of South America for much of the 16th, 17th century. Anyway, it's not like that now, and obviously it came at something of a cost, the mountain that eats men. But she was diagnosed in Spain during a pregnancy, and it was about her third or fourth pregnancy, and certainly wasn't her first pregnancy in Spain. But at the time she was noted to be somewhat bradycardic, so she had an ECG and then she had some Holter monitoring and was found to have bifurticular block and sinus node dysfunction. So at risk of going into complete heart block or of having long pauses, so she had a permanent pacemaker inserted into labour. She was completely symptom-free and has remained completely symptom-free. These are her cardiological investigations from last year. So she had an echocardiogram, and the first line sounds great: normal LV size, normal wall thickness, reasonable ejection fraction. And then there are some slightly more subtle changes which you might not pay too much attention to ordinarily, other than that we know that she now has Chagas cardiomyopathy. So she's got some reduction in function in one part of the left ventricle. She's got a slightly dilated right ventricle, and atria are also slightly dilated, which ordinarily you might not pay too much attention to. But she's heading towards a cardiac MRI and is under our cardiology colleague, Dr. Oliver Gutmann at Barts. As alarmingly, she has episodes of ventricular tachycardia and supraventricular tachycardia and episodes of bigeminy and trigeminy on her 5-day Holter monitor, which are entirely asymptomatic. And it calls to mind some of the patients I remember seeing when I first started seeing patients with Chagas in the clinic, who would sit down and describe growing up in a village in rural parts of the Gran Chaco, and people in their teens, early 20s, dropping dead playing football on the patch of grass that the village called a football pitch. And these were almost certainly people who had clinically silent Chagas cardiomyopathy who suddenly had dysrhythmic deaths. So I'm going to finish there. There's a whole lot more stuff that occupies a disproportionate amount of our time in the clinic, particularly patients who are having kidney transplants, or who are having cancer treatment, in whom we have to keep a lot of monitoring on, but I haven't really got time to go through those now. I guess my summary is that we have a population of people who have been infected a long time ago and haven't been re-exposed since then. Quite a lot of our patients are PCR positive. I'm always surprised when we see people who are PCR positive decades after leaving their country of origin. Increasingly, our patients are happy to give antiparasitic treatment a go. And you will hear more about that from Pao a bit later on. And our population at the moment is driven in large part by these community-based screening events that have been run through the Chagas Hub. And that's why we have such a high proportion with indeterminate phase disease. We need to do something about pregnancies, and we are struggling somewhat with that. And that's the subject of the next sort of 20 minutes. We're going to have a little in-conversation, which I encourage you all to contribute to. But that's all I wanted to say about our clinical practice for now. Does anybody have anything they'd like clarifying before we move on to the next bit? Oh, it was all clear. Okay. In which case, can I ask Christina and Geraldine and Haley here? Haley, there you are. And Natalie, just to come up to the front so we can just have a conversation about antenatal screening. And I guess we'll try and do it here. All right? You need to grab a chair, I think. You should sit down.
Try to avoid it directly in the spotlight.
So I'll kick off, but there are other people in the audience I know who will have things to say. Is Anna here? Did Anna Garcia-Mingo make it? Not yet.
I think she was running a bit late.
She's going to be a little bit late, okay. But Peter, I'm certainly going to come to you as well about this, if you don't mind. The title really is Antenatal Testing for T. Krusei. I hope I've explained to you why we think this is something that is worth doing. I mean, it's not just we think this is something worth doing, it's recommended. But it's fair to say that we have been struggling for quite a while to make it routine practice. Who would like to start explaining what the problems might be?
I think it's done.
Why don't you start, Christina? I'm going to give you a microphone as well. That will probably be sensible. Sorry. We've only got 20 minutes, so
Yeah.
sure.
So hi everyone, I'm Christina. I'm a nurse, I'm a midwife by background, and back in, 2016, 15, 16, I was working in the Hospital of Tropical Diseases, and we came up with this whole Chagas hub through, I was basically applying for an IHR fellowship to try to implement Chagas testing. This was at King's College Hospital, the SCT, and UCLA. So, you know, it took us, I don't know, it all started to kind of build all the relationships with the key people at the hospitals, you know, with the directors of midwifery, the infectious diseases midwife, consultant midwives, and commissioners, and so many key people and decision makers there. So it's kind of months to go through the 1,000 conversations to try to make the case why Chagas was important. And so the people, most of the, it's always, you know, you always find someone who kind of becomes the key driver at that hospital and is very keen to move things forward. So you have to approach like 10 people until you find that person, right, who is very willing to implement it. And so we have those key people at the different hospitals. In one hospital was the obstetrician, in another one was the consultant midwife, and everybody were very keen to move it forward, right, and finding a way to implement it. It was, I mean, one of the challenges was that we didn't have data, so there's no data. That's the problem, right? So the first thing that they will ask you when you want to implement something is, where is this coming from, and what is the data, regardless of, you know, recommendation. And so we did some audits to try to find out, you know, how many pregnant women born in Latin American countries we had, just to get some idea about the estimates or potential estimates. And based on that, implementing it as such was very difficult. We needed funding, whether it was through research or through quality improvement projects. So we needed to make a case, a business case for them to be very keen to implement it. Then yes, there was the thing of, you know, training the staff, incorporating training in the staff, and incorporating it into the online system so they could request it and so on. But yeah, that was the main challenge, I guess, we faced through the years. And I guess, yeah, by the time you engage with some people, they leave, and then you have to re-engage with somebody. You know, not having someone there full time was, I think, one of the main barriers. And so I think there is variation in the different trusts anyway at the moment. So
yeah, and so part of the solution is,
we probably have an update better than we now at the SDG.
but so part of the solution is finding a champion, isn't it?
That's the thing, right? Yes. Yeah, you may want to give an update at the SDG, because I don't think we reach, I don't know where are we at the moment.
Geraldine, do you want to just introduce yourself?
Yes. So my name is Geraldine O'Hara. I'm a consultant in infectious diseases and general medicine at St Thomas's Hospital in London, which serves two boroughs, Lambeth and Southwark, which have some of the highest numbers of Latin American migrants living. And we have a significant number of women born in Central and South America delivering babies in our hospital. And we, as yet, do not have Chagas testing implemented within our antenatal service, despite previous work and ongoing work. And Bill Newsholme's here, who's my consultant colleague at GST2, and can speak to some of the historical challenges with engagement with different groups. I think one of the things that we absolutely have to be mindful of is the burden of work that already exists on midwives in terms of screening for domestic violence, for drug abuse, for other infectious diseases. And whilst this is key to us and of interest, what we need to devise and develop is a system that is almost faultless, that's so easy for them to use, and the referral pathway that exists afterwards, so that there is no challenge there. And this is really what we're trying to work towards. There is an enormous, I think, lack of awareness amongst our obstetricians and indeed our obstetric medicine physicians about it as an illness. And one feels that eventually what we'll have, we'll have is transmission, and then we'll manage to get people engaged, and that just seems so sad and such a massive challenge. One of the things that has been helpful, because we have obstetric physicians as well as obstetricians, is we work with some of them in our capacity as general medics, and they are a bit more engaged in the process. They've got a bit more bandwidth to it. So that's been a group that we are working with quite closely to try and get this up and running. And I think the other thing is, obviously, we're one teaching hospital in South London. Actually, what you want to be able to do, and I think Mauricio is building on this at King's, is to try and have a system that's the same across all the areas, because women book some places and present then others, and some of the community staff will be employed by both trusts. So the design has to really be thought about quite carefully. One of the things that's been really helpful to us has been Natalie's study translating epidemiology for Chagas into data, where we've looked at all of our, for example, all of our patients with HIV, we've managed who have Latin American origin, we've managed to get screened. And because that's got some research funding behind it and NHR portfolio sponsorship, and it doesn't make work, people are a bit more engaged, and I'm really hopeful that we can get that in place. And then that gives us some data to kind of beat people, a stick to beat people with, if you like. All right, thank you.
I suppose just to add to that, is this working? You can hear me. So we have got antenatal screening up and running with Hayley's help at UCLH. But UCLH, unlike King's, unlike Guy's and St Thomas's, isn't a hospital that sees a huge number of Latin American women. It sees barely any Bolivian women, for example, or women from other highly endemic parts. So there's quite a few women from Buenos Aires or from Santiago in Chile. So although we've had it up and running for a couple of years, it's not really the ideal target hospital to start a project like this, but we did that because it's the home of the Hospital for Tropical Diseases, and we thought it would be the easiest place to start. Now, it wasn't easy at all, but it is kind of up and running. But I think the reason it's been relatively easy there in comparison to King's or Guy's and St Thomas's has been a lot to do with your help, Hayley, because it hasn't felt like, from the midwifery point of view, there's been huge concerns with implementing something new, and I was wondering if you can share any reasons you might think that could be, or anything that we could try a little bit differently at King's or Guy's and St Thomas's, which would be the really important places to get this up and running. If you're happy to.
Hi. Oh, is this on? No. Yeah.
It is, yeah.
So I'm Hayley. I'm the ID midwife at UCLH, and before that, I was ID midwife at Guy's and St Thomas's for a little bit. And I've never heard of Chagas when I worked there.
But it's interesting to hear that they have an ID midwife.
Yeah, they do. She's only paid like 2 days a week, which may be why it's not implemented there as well. The first time I heard of Chagas as well, you emailed me and I thought, huh, what's this? So I guess one thing is you need someone that's passionate, like you were saying, you need someone that's going to keep driving it. Because you've got to think about who's responsible for offering it, who's responsible for chasing it. Is it the midwife that's never heard of it before, or is it your links with tropical diseases? So you've got to think about how the antenatal clinic links in with tropical diseases or parasitology, wherever it is. Another thing is data collection, finding who's at risk. It's not mandatory to ask where someone's born or where their mother is born. We ask ancestry questions for haemoglobin, OPI screening, but we don't ask specific. So if you wanted to even go back and see who would qualify, you wouldn't even actually be sure. So a lot of it is to do with identifying who's at risk as well. What was the other question? Implementing.
Those are the key things to study things for other trusts to know about.
Can you tell us a bit about the pathway? How does it work from the beginning? So a woman goes to the antenatal clinic, and what happens?
I'll talk it through basically, and then I'm sure Hayley can add a little bit of detail. So, as Hayley mentioned, when women book in for their antenatal screening appointment, they're asked a whole load of questions, and the infectious diseases screening part is really just a very small part of a much wider process. And they were already being asked about which region of the world they're from for a hemoglobinopathy screen for things like thalassemia. But they weren't being asked about the specific country that they were born in, which we would need for Chagas disease. I mean, when we talk about Chagas endemic countries, we're talking about Central America, Mexico, and South America. We often say Latin America, but the two terms aren't really interchangeable, because Latin America could be your Spanish or Portuguese-speaking countries in the Caribbean, for example, which aren't endemic for Chagas. So within that question and that pro forma, which is using the online medical records system called EPIC, but there's, as lots of you know, different systems in use in different hospitals. An additional question was added in asking about Latin America and asking about which country of birth people were born in. And if they were born in a Latin American country, at first that's all we were doing, just identifying that, and then we'd go into the medical notes, identify those people and put a prompt in the notes for at their next appointment them to be offered Chagas screening. So it was really quite a light touch intervention at first, and we were getting some people but missing some people, and it was reliant of course quite a lot on the midwives at that point, and we did quite a lot of education sessions with the midwives to try and get people feeling a bit more confident about talking about Chagas, because it is completely new and it's not something that you can learn about overnight. It's quite a lot that you need to learn about, and for a lot of the women that are being identified, they might never have heard about Chagas as well, so you've really got to start from scratch with a lot of people. But slowly we've kind of gone and intervened a little bit more to the point where now this is being done as part of a research study. And so when women are identified as being from Latin America, they're being consented by the midwives to be contacted by ourselves, the study team, to take part in this research study. And often now the midwives are very happy to just explain Chagas and actually take the Chagas blood test there and then. But that's taken a couple of years. And I don't know if Hayley, you could shed any light. I assume that there's a couple of midwives that are just doing it all of the time and completely happy, and maybe some people that are newer to the department or less familiar with it that aren't doing it at all. But I would say that's taken about 2 or 3 years to get to that point. It hasn't been quick, and we're still not getting everyone. And there is also a question at the end of this study, probably at UCLH there shouldn't be too many financial concerns with carrying this on. But if we were to implement this as part of a research study in a hospital with many more Latin American women, like in Guy's and St Thomas's or in King's, the financial cost would be greater there. So we would just need to think about what the end game is. So I think that some of the reluctance for even being a study site is coming actually more from managers that are concerned about what we're going to open up with this study.
I can see Bill nodding. Do you want to speak to this?
Yeah, I mean, I'm more than happy to say something about the historical barriers.
We've only got 20 minutes though.
And if you could then pass the microphone to Peter, because I'm sure he's got...
I'll curtail my ferocity. So I'm Bill Newton, I'm one of the other ID physicians at Guy's and St Thomas's, and I know Christina from 2016 when we had many interesting meetings. I guess there seems to me to be 3 barriers that were causing principal problems. One was complete lack of clinical awareness. So, for instance, we've got a big paediatric cardiology unit, neonatal cardiology unit. They were completely unaware of this as a problem, and promised faithfully that they would include T-Cruzi screening in their neonatal cardiomyopathy screening. As far as I can tell, still aren't. The second barrier was around IT systems. We had absolutely no way of tracking who was delivering within the organisation from Latin America. Our then IT system just could not cope with that level of demographic depth. So we couldn't even go to the midwives and the obstetricians and say, you have delivered X hundred Latin American women in the last however many years. We probably can just about do that with EPIC now, but we clearly couldn't. And then the third barrier was around finance. So I think we got really good buy-in from the midwifery side. The midwives were more than happy to support the research projects and things, and the obstetricians just said no. And the principal reason seems to be that obstetric funding is by block contract. And so for a tertiary referral centre that gets a lot of complex women and a lot of complex deliveries, the addition of extra testing pathways and extra follow-up pathways, the obstetricians just said financially they could not support it, which just seems insane, tragic. Other words.
Thanks very much. Okay, I'm nothing if not persistent, but this is going to tax most people what I'm about to tell you. So, long ago, and I take off my hat to the panel in front of me for their due diligence in doing this from ground level upwards, it's backbreaking work, and people leave, and the amount of effort that's gone in for the return we've got so far is enormous. And I think some compulsion is also required. So there was ages ago when it was called Health Protection Agency, the Migrant Health Guide, that says clearly you should be screening pregnant women for Chagas if they're at risk. Government policy, if you like. So it wasn't being done. So I wrote to the National Antenatal Screening Panel that mandates that you do syphilis screening, all the rest of it you know about. I said, what about it? Sent me evidence. I said, oh yes, very good, but it's not our problem, it's focal, and therefore do it with the providers. My heart sank. So I wrote to 23 obstetric units, all the units in London, got one reply from my own hospital, nobody else replied. The clinical director of obstetrics from my hospital eventually stopped taking my phone calls and ignoring my emails, so persistent was I. So we then took it to the Advisory Committee on Dangerous Pathogens that I sat on for 9 years. So I ran out of goats in the end. And they contacted the Royal College of Obstetricians who said, not us, Gov, it's too focal. The only people interested were the Royal College of Midwives, and I take off my hat to them. They were supportive. It still didn't happen. So 9 years down the line on the ACDP, we put in a proposal to the antenatal screening programme with strong support from the ACDP and also informally high up in the medical hierarchy within the Department of Health. And it's now with the national screening programme to see if they will finally say you should be doing this. My own feeling is that you'll do great things locally, but unless there's some kind of mandate that you've got to do it, it's always going to be a battle. And that's going to go nowhere unless we've got that compulsion. That's all I want to say. Thank you.
Thanks, Peter. Sadly, I think I agree with you. We've only got a couple more minutes. Does anybody want anything else to add? Because if not, I'm going to ask Anna just briefly to speak. Yeah, you're on in the hot seat now. And the reason for this is because Anna is doing something slightly different, which I think might well be a stopgap at least until we get a national policy, which is not worrying too much about the pregnancy.
What do I do?
I don't know, tell us what you do.
Well, yeah, so I work in the Whittington, which is a very small hospital with 100 beds, but a big community service, but a bit of a disproportionate maternity for the size of the hospital. And it gives us a hope to listen to PLC because it's been, for me, it's been almost 3 years and a half, 3 years. So at the moment we are doing I'm doing an audit. So I'm testing the mums that have been, had a baby with us in the last 2 years. And basically we're, I've got here Sophia, medical students, Spanish, helping me with calling the ones who need consent in Spanish. And so getting all the little ones as well on board since they're in medical school. And we're trying to consent them to use their booking bloods to test them for Chagas, and that's what we're doing. So we've got 3 different pathways open at the moment. That's the first one, so do it prospectively. We will miss the first pregnancy. At the moment I'm using it as an audit, but it might be, I had a meeting with the head of the Department of Obstetrics, so he said that might be one way of doing things. It's prospective, it's not ideal, but it could be useful for the second pregnancy, and also it would just get you some data to put on the table. That's option number 1. Number 2, I explore with the Chagas Hub doing a rapid test, so doing an RDT in clinic rather than like serology, but that's been explored, and it feels that that's a bit too much of a fuff. And they're feeling from the midwives and the obstetricians that it's not going to work. It's going to be too complicated. What else do you want me to share with you? The third aspect is that you always get the midwives very excited. They always want to listen to this recording. But then again, it's a similar flavour to what Prof. Kudini was saying. So we're a bit stuck, but we'll persevere. I think that's the main thing.
Yeah, thank you. I mean, I think the interesting thing here is the efficiency with which one can do screening of everybody who delivered in 2023. You get a line list, you get on the phone, you've got serum stored, you just get on and you crack on and you do it. And it doesn't require the midwives on a day-to-day basis to filter out who are the people who need testing during this pregnancy. It does mean that you miss that neonatal period and you're playing catch-up, but it might be a far more efficient way to do things in the interim. So,
and you need good communication with your reference lab, which we discussed this initially. We're going to be sending you samples. Are you happy with this? Our numbers are low, we are not. Chagas symptomasis, so we just send samples and it doesn't feel like a big burden to the lab. but I can understand how. But I wanted to build also on something that has been discussed before, which is how to find these women. And you're absolutely right. For us, it was really tough because we're using the thalassemia screen, and they mix the South American women with North African. You tell me what they have in common, because I still don't understand it. And that's how we found them. So that was the first step, and we're finding it really tough. So then we use the surnames, which I think is an awful way of screening people. But two surnames with a Spanish sounding, and so we use different routes, whatever works. We tried everything.
Lovely, thank you. Right, we've used our 20 minutes very quickly. I just want to say thank you to you four for coming and stepping up and sitting in front of the audience and confessing that we're struggling. But actually, I think we're getting there. Hayley, thanks very much. I think it's working at UCLH. There is hope. So thanks very much for the four of you. Okay, let's just like that. Get rid of that. I think it's all. Get that out of the way for you. Wonderful. And then you can use that to navigate. Okay, super. So I'm now going to give the floor to Pau, who is the first author on the multi-bends trial and has come specially to speak with us today. Over to you. Thank you.
Well, thank you for the invitation. My name is Pau. I'm a medical doctor in Vall Hospital in Barcelona, and I'm here to present the results of our study and to talk about the new schemes for benidazole treatment for chronic Chagas disease. Most of you already know some of the data I'm presenting, but I think it's important to go through this introduction to understand our results. So Chagas disease, as you know, it's a protozoan disease caused by Trypanosoma cruzi, endemic to Latin America with this patchy distribution. And even though it affects more than 6 to 7 million people around the America or the globe now, it is considered one of the neglected tropical diseases. Due to migrations, especially from 2000s, lots of individuals have migrated with Chagas disease to other regions, non-endemic regions as North America, Europe, or Asia. I won't go in detail on the life cycle, but it's quite a simple life cycle with the implication of a vector, a bug, and a host that could be a mammal as human. And these vectors are triatomine bugs. There are several species, more than 150 species that can transmit disease, and their capacity to transmit the disease is not the same. So this explains why some places are very, very endemic and others not. But apart from this vectorial transmission, there are other ways of transmission as vertical that we already talked about it. The oral one, which is usually as outbreaks related to the consumption of sugarcane or acai, especially in the Amazon basin, and also through blood transfusion and transplants, especially heart transplants. So Chagas disease and Trypanosoma cruzi, it's not an homogeneous parasite. Nowadays, the most accepted classifications of Trypanosoma cruzi distributes it in 7 different clades or DTUs, discrete typing units. As you may see here in this graphic, these geographical distributions are different. So TC1 is the predominant in Central and North and South America. TC2 is the predominant in Central Brazil. TC3 and TC4 are mainly sylvatic, so affecting difficultly to the humans, and TC5 and TC6 are the predominant in the southern corn countries. So the importance of these classifications is because there's some correlation between them and the clinical presentation. For example, TC1 can produce cardiac involvement, and TC2, 5, and 6 can produce both cardiac and digestive involvement. And besides, this classification, also these DTUs are related to different susceptibility to benidazole. There are some studies that have related different susceptibility. The data is quite controversial, so we don't have like strong evidence, but it sounds that it could display some different results, and this is important to understand our study. So the clinical manifestations, we divide Chagas disease into clinical phases. The acute phase characterized by the presence of the Trypanosoma cruzi in blood, and the chronic phase that it's diagnosed by the serology, 100% with positive serology, and as Dave said, 20 to 30% of individuals with a positive Trypanosoma cruzi detection, DNA detection by PCR in blood. Clinically, about 70% will remain asymptomatic, but about 30% will develop the organic involvement, mainly cardiac and also digestive. And also, due to the pandemics of HIV and the use of immunosuppressive therapies, we have now reactivations, which usually have a more severe clinical course with meningoencephalitis, with myocarditis, and a high mortality. Even if the disease was described more than 100 years ago, we still have only 2 treatments available for Chagas disease, benidazole and nifurtimox. They are indicated for the treatment of the acute phase and of the reactivations, but we have less evidence for the chronic phase, and especially for those who already developed cardiac manifestations. We know that the treatment is not useful for them. And one of the key points in Chagas is how we measure treatment response. Nowadays, the only accepted criteria to say that somebody has been cured is the negativization of the serology. The problem is that its latency is more than 10 to 20 years. And personally, I think that now with the new techniques, nobody gets negative. But during the last years, we came up with the PCR. The PCR, we still have a problem of standardization, have different techniques, and it's difficult to compare them. We still don't know which is the prognostic value. What does it mean to have a positive PCR in blood? But during these years, it has been used as a surrogate marker to treatment failure, and it's quite different. We usually measure treatment success, not failure, but in Chagas disease, it's what we have. So when a patient presents a positive PCR after treatment, we consider that it has failed. So the major problem with treatment with benidazole are the adverse events. They are very, very common, mostly mild, but in 15 to 30% more or less, they can lead to the definite interruption of the treatment. These secondary effects are well described. They follow a temporary distribution. The earlier are the digestive secondary effects. Then during the 2nd to 3rd week appear the cutaneous reactions, which are the main cause of treatment interruptions. During the 4 to 5 weeks appear the hepatic alterations and also arthralgias, and the neurological manifestations are usually the later. So we are waiting for new drugs for Chagas disease. One of the main lines of research lines that we have been working with is the optimization of the treatment with benidazole. So we have some evidence that, for example, for the use of lower doses. This first study on the top, it's a pharmacokinetic study using benidazole at the standard doses. They compared how the benidazole was eliminated from the body from children to adults, and we saw that children has lower levels because the clearance of benidazole was much higher, and even though they presented almost 100% of effectivity, so maybe we could need lower levels of benidazole. And the second one is a study performed in adult patients. They compared in a mathematical model the standard doses of 5 milligrams per kilo and the half of the dose of 2.5 milligrams per kilo per day. And what they showed is that the half of the dose was enough to maintain the recommended levels of benidazole in blood. So it could be an option. We also have some evidence of using higher doses. In this mirror model, the effectivity of benidazole was clearly related to the dose that the mouses received. And we also have some experiences already in clinical trials. The Stop Chagas trial used 400 milligrams, a little bit higher of the standard dose, and without seeing more adverse events. And also, we have evidence for shorter durations. This first study is also a murine model. They used only a quarter of the total dose, the total duration of the treatment, with the same effectivity than the standard doses. And this observational study followed up the individuals who had to interrupt the treatment because of adverse events with a mean treatment of only 10 days, and they reached the same percentage of seronegativization as the ones who received a complete treatment. So before that we designed our study, the Bendita trial has been published, and even though the objective of this study was to compare the treatment with benidazole with fluconazole, they included a treatment arm of only 300 milligrams. And they saw that the effectivity of this arm was similar in comparison to the standard free Jarmen. And they saw very, very little secondary effects. The problem was that this study wasn't powered for this reason, so the conclusion wasn't robust enough to make this recommendation. So here's our clinical trial that was recently published in Lancet Infectious Diseases. It's a phase 2b clinical trial, randomized, double-blind, and stratified by country. It was financed by the European Union, and here we include chronic patients diagnosed by 2 different serologies and with a positive PCR. We exclude those with immunosuppression or pregnant, previous treatments, those who had severe renal or hepatic impairment, and those with severe cardiomyopathy. Patients were enrolled in Colombia, in Brazil, in Argentina, and in Spain. And in Spain, all the patients were from Bolivia. This is the scheme of the trial. We used the block randomization, and we assigned 1 to each treatment arm. We compared 2 new schemes to the standard dose. CT means the current treatment. It's benidazole 300 milligrams per day. Then we used a low-dose treatment of only 150 milligrams for 60 days again. And then a short treatment of 400 milligrams, but only for 2 weeks, followed by placebo. During the treatment phase, we performed the PCR just to see the dynamics of the parasite. But during the follow-up, we performed the PCR during the month 4, 6, 8, and 12. And these PCRs were the ones used to determine the objective. The main objective of the study was the sustained parasitological negativization. It means that you need to have all PCRs negative to consider a success. And the main safety objective was the proportion of treatment interruptions. Well, we included 245 patients. Here's the distribution. In the intention to treat analysis, all the loss to follow-up were considered treatment failures and included as treatment failures. And in the per protocol analysis, we only include those who followed the scheme, the protocol. But if they presented with a positive PCR before they leave the study, we also included them as treatment failures, just to be more conservative in our results. So for the randomized patients, we had 61% of females with a mean age of 47 years old. 21% had cardiac involvement, mild cardiac involvement. And here are our results. So in the intention to treat analysis, we had 58% of success, of treatment success, and in the per protocol analysis, 68% of individuals with treatment success. As you may see here, there's no differences between treatment arms, nor in the intention to treat analysis or in the per protocol analysis. We also see the distribution of failures, and as you can see, there were no differences again between treatment arms. And one of our most shocking results were the distribution of failures between countries. These differences were astonishing. Here on the left, we have the intention to treat analysis and the per protocol analysis. As you may see, Brazil participants had as maximum 15% of treatment success in all groups and in all treatment arms, and compared to other countries was much lower. We also performed a sensitivity analysis considering the organic forms, and we saw that those with cardiac involvement present lower results also. And one of our hypotheses of these findings was maybe the origin of these patients were differently distributed. And as you can see here, Brazil and Colombia had more patients with cardiac forms, but Brazil performed the worst and Colombia had the best results, so it seems that it doesn't explain these differences. It has been already described, these differences between organic, the cardiac form and the indeterminate form in other studies.
So may I ask you, were the numbers comparable of patients in Colombia and Brazil?
The numbers?
The number of patients were comparable?
Yeah, all the countries had the same number of patients, so it was stratified by country, so the inclusion were the same. I think it's 60 patients per country. So when it comes to adverse events, we observed 76% of the individuals with an adverse event. As expected, the most common were cutaneous reactions, followed by digestive disturbances and neurological alterations. And when we compared the different treatment arms, we saw that the experimental arms had lower adverse events than the standard treatment. And when we compared the definite interruptions because of these secondary events, we also see that the short treatment has the lowest rate. We also determined the benidazole levels just to check if the patients were taking the drug. And here you have the results on the day 15, which is considered that the day that you reach the steady dose. And as you see, there are not significant differences between countries, and the proportion of the benidazole levels it corresponds to the dose administered. And when we try to correlate these levels to toxicity or treatment success, we didn't see differences. So it seems that it's not the only explanation. So as a conclusion of our study, we saw that the new schemes with reduced accurate dose were similar to the standard doses. But in Brazil, sustained parasitological negativization were clearly lower than the other countries. And considering the toxic profile, it seems that the short treatment could be the most interesting new scheme. But obviously, these results should be confirmed in a phase 3 clinical trial. And what's next? There are 3 studies that are already recruiting patients. The TESEO trial it's been performing in Bolivia. They will try to compare benidazole to 40 mg at different doses again. The Chicamocha trial or the equity trial is being performed in Colombia. They are still recruiting patients again. And they are using lower doses but for a longer treatment. And finally, the Betty trial, which is held in Argentina. They will try to compare also lower doses and shorter regimens in pregnant, in mother-child being age after pregnancy. And after our results, we have started new trials to confirm them. We have started a phase 3 clinical trial with the DNDi initiative, and we are planning to compare these 3 doses of benidazole, the standard dose, 30 days course and a 2-week course, in Colombia, in Brazil, and in Argentina. And in Brazil, we showed to the government these results, and it has been a mess because Brazil is now trying to treat people. Till now, they weren't treating. And we now want to compare if our results are similar in other states of the country. Our clinical trial was performed in Minas Gerais, in the southern east of the country. And we don't know if other regions of Brazil will perform the same or not. So we will try to give the same dose of benidazole, the standard dose, in other states. And in Minas Gerais, we will compare the standard dose of benidazole to 40 mg to see if we have an option for these patients. So after all these trials, we will get these large amounts of information. We will be able to compare different regimens and see what's the best for these patients in terms of toxicity, in terms of efficacy. Also for nifurtimox, we'll have some new information. But I think that we need to keep in mind that this is not the solution. We need to find new drugs. Benitazole is toxic, its effectivity it's not good, so we need to keep looking for new drugs. So thank you very much for your attention, and now if you have any questions, I would be glad to answer you.
Right, I'm sure there's going to be questions. I see one already.
Thank you. Sorry if it's a challenging question, but I'm really interested in the poor sort of treatment outcomes for Brazil, and I was wondering if you could shed some light on why that might be, if it's a true difference. And I don't know if Debbie said that it would probably be quite interesting to know about the PCR protocol that was being used and the experience. And the experience with treatment as well in Brazil, because they're not treating people. So any ideas about the reasons why behind that finding?
We think that it's something of the parasite. It should be the parasite. The PCR protocol of all the countries was the same, and we had like external controls of quality controls, and also we repeated some of the samples in the central laboratory, so the results were okay. And we had some previous experiences of doctors treating patients there in Minas Gerais, and they already said that they have seen this all their lives, but it's not published, so we didn't know that. And we are now performing a second study there. We are recruiting all the participants of the multi-event trial, and we are already recruiting them, and we have some, I think that 13 positive blood cultures, not PCRs, blood cultures, positive blood cultures, which is difficult to obtain, so they are still positive. And we will try to sequence the trypanosoma and do some tests in vitro and in vivo to see what happened there.
I mean, it's really interesting that doctors have been saying for years, well, we treat it doesn't work, so we don't treat it any longer. They demonstrate it. Michael spent a lot of time in Brazil.
There are lots of things that could be said. But the presence of T. cruzi in those different places, they're different lineages. So the lineages in Brazil are different. And if you look at some of those experiments also, the organism is hiding, and we get more probably from over there about the details. And it's extraordinarily, well, it's very unlikely that you're going to get the bounce back after 2 years only of that particular lineage from what we've seen in the lab. And also, we know that in some of these infections, you get the organism hiding deep in the blood, not in the blood, but in the muscles of the organism. So I think that is something essential to do. In one of the early photos, you gave one of our earlier pictures in the different lineages and where they are. So I think it's important to continue to consider that, and also to consider the different behaviour of the different organisms. We've had one of your presentations which showed work that we've done was that bounce back of negativity after 6 years. I think we put in that was looked likely that you could have decline in the amount of that organism, those organisms there. I'm a bit muddled in a moment with that. There are so many different elements here that I can't present all of those issues at the moment, but there are several other ones, particularly whether you're looking at particularly at babies that are new. That's another issue. There's a bundle of issues that I think we need to have a look at in detail. And you can see those differences in the lab, and you can also see those differences looking at individuals.
Do you think it is about lineage? Is it Is it that clear, or is it?
I think it's more complex than only the official lineages.
Yeah.
Actually, there are several groups that are proposing different classifications and trying to reclassify Trypanosoma cruzi. I don't know, but we need to know what happened there in Brazil and get more information, and this would be a great opportunity to know, to see what happened with these individuals.
Yeah. So it feels like it's more likely to be the parasite than the host, but it may not be along lineage lines because the lineage classification may not be the best way to classify it. Yeah.
Yeah, kind of just to add to that, we've looked at a lot of strains in the lab for benzoyl sensitivity, and whether they're resistant or sensitive doesn't correlate to what lineage they are at all. You can have highly resistant DTU1, TC1 cells, and highly sensitive ones, and it's the same. It's not related to the lineage specifically, as far as we can see.
And I guess it's also interesting that you're able to culture from so many of those Brazilian patients, suggesting they may have a higher parasite burden. Is that's sort of what you're implying? Is that right?
Yeah, well,
maybe.
It's our hypothesis.
Yeah, sure. I'm not putting words in your mouth.
Thanks. Very briefly, I think more attention needs to be paid to dormancy, because Leishmania closely related toxoplasma, you kind of don't cure those. You get them better, or they get better themselves, but they're still there. And now with malaria, we're finding that the ring stages of P. falciparum can go dormant in the face of artesunate and wait till it's gone. And I think that's an area that needs much more attention in the T. cruzi chemotherapy area.
This is one of our fears, reducing the treatment, but it seems that the dormant stages of Trypanosoma cruzi last more than also the 2 weeks treatment, so it's not the problem but till we get more information, I think it's the most important thing is not to harm patients. So if you can reduce the exposure to benidazole and then see what does it mean, because our study is to negativize the PCR. It's not curing anything. There's no clinical outcomes. There's nothing else. So I don't know. We still have a long road to go through.
I'll come to you, Michael, next. Did the Bendita trial have a Brazilian site?
Bendita was in, I think, Bolivia only.
So could it be that we've thrown away rabuconazole and it would work very nicely in Brazil?
So what about is not the parasite but the host? So for instance, a idiosyncratic way of distribution of the medication in people from that part of Brazil, or people's cultural ways of dealing with things, injecting the medication. I imagine that was controlled, but is there any particular thing, because it's very, very specific in a whole continent, and just that little region is interesting.
The protocol was very strict, and we did these benidazole levels to check if they were taking the pills. So, and as I showed, the benidazole levels were similar, so it doesn't seem that it's a problem of attrition. But I don't know if they, because we measure plasma levels, but we don't know what happened to the cell, which is where the trypanosoma is. Too many questions has been
Mauricio, you're sure this isn't the Spanish-speaking Colombiano having a go at the Lusophone Latin American? Right? There's a bit of competition here.
Well, possibly.
Excuse my ignorance about the PCR, but I guess do you get quantitation, and is the load distribution on PCR, the same in the different places, right? Maybe all the people in Bolivia have very low load positive PCR, right? Just at the cutoff of positive negative, quite easy to drop low. And in line with the fact that you were able to culture from Brazil, maybe they all have very low CT values, absolutely hooching blood, full of trips. And actually, if you compare their baseline and end line, there may have been a significant drop in the quantity of cruzi in the blood without going negative. I don't know if you can really
we have our PCR. It's not a qualitative one; it's a semi-quantitative. So we are able to more or less quantify, and the levels of the trypanosoma cruzi were very similar between countries. So yeah, it was another of the hypotheses, but no. We haven't published these results yet because we are doing a more specific analysis of this data, because we have lots of data with this clinical trial, and we are planning to publish more.
Just one small point, that is for the diagnostic method, so ELISAs, for example, and also the other tests you have available, a rapid diagnostic test, for example. I think there's scope, much greater scope for using those agents. To give you one example, years ago I worked in a particular country and I was there asked to help with the identification of cruise I have, how much is there, how quickly can we get rid of it, and I was involved in that to look at the distribution of Chagas in that entire country. It cost a relatively small amount of money because it was easy to make those ELISAs, for example. You can do 100 cases with one plate, if you like. So I would just suggest that you may consider that as well, as we've just said about the decline of IgG1 in treatment and how that gives you some implication as to whether you've got cure or not. So consider some of the careful ways of doing that, but there are some technical advances that could be done. And also, as has been said, don't rest too much on the lineage abilities, but they are in a particular area. That's probably not the example. And if you're using only individuals who are infected for two weeks only, I think that is very optimistic, and I think you've seen that in those particular, in certain particular regions.
Anna?
Just a very basic PKPD question actually. Do you know the population racially, just going back to Maurice's question about race, for instance, Brazilians are, all kind of passports. So are you going to trial in different, apparently it's the most diverse passport country. So you're going to trial in different races, so indigenous, black, or populations, do you know anything about that?
We are not able to do this in the region where we are doing these studies because they are mixed of European ancestries and American ancestries, but for example there are no blacks or the low population of blacks in this region, so we won't be able to make these comparisons. But as you said, the population of Brazil is very mixed, so we would expect if it was something of the background of the individuals, we would expect that, for example, Bolivia, that has a more conserved background, had these differences or different, but in Brazil, we don't think.
On your sites that you were mentioning about your PKPD,
yeah,
the levels were pretty much standard. There were no big difference between sites, was there?
So how long are you planning to follow these patients up? Because maybe that in 10 years they will come back with positive PCRs. How long are you
we follow them for our patients for life in Spain.
For life.
Yeah, we yearly. But in Brazil, for example, they are starting to do this, but they don't have the capacity to do so nowadays. But with those who we treat there in Brazil, we try to engage them in our patient clinics and follow them. Actually, we are, 10 years ago, we published the posaconazole trial that compares the posaconazole with benidazole. That was a total failure. And we have followed all these patients during 10 years now. And 2 patients had a positivity 5 or 6 years after the clinical trial. And so that it's another point that goes for the follow-up for life for these patients. Because we don't know the kinetics of the parasite. We still have many questions in this regard.
You're sort of immersed in this clinical trial world. What noises are people making about tests other than parasite markers that might shed some light on whether or not they have any impact upon the evolution of disease? Is there any work going on in that area? Tell us about.
Now we are performing some studies in trying to find biomarkers to predict what's happening with this patient. Actually, we are planning to publish a study that we compared people with Chagas disease in the indeterminate phase, people with the cardiac phase of Chagas disease, Latin Americans with cardiac diseases, but not for Chagas disease, and Latin Americans, Latin Americans, and the patterns are quite different. Actually, the cardiac forms are very similar, independent of which is the origin of the cardiopathy, while in the determinate phase, individuals are different from healthy ones and also from cardiac ones. So something happens in the determinate phase. They are not healthy, but it's important to see which is the marker or something that can make us predict what will happen with these individuals. And we are trying to, now we are starting a cohort in the whole Spain, and we engage 7 hospitals by now, and trying to follow them for a long period and extracting the biomarkers and making a serotype. We'll see. Lots of projects.
Well, final question, unless anybody has another question. And it was about the differential parasitological response in people with determinate and indeterminate disease.
That's a question.
How does that work?
We didn't expect that. Okay. Actually, I don't know how to explain this. Some theories said that the cardiac patients has a higher parasite load, and that it could explain these results. Actually, I don't know if it's the Stop Chagas trial already showed differences between cardiac forms and indeterminates, but nobody explains that, and I don't know why they look different.
But to be clear, it's not explained by parasite burden as far as we know, is it? Or is it?
I don't know, actually.
Fine.
Yeah, I don't know.
Okay, good. Are there any final questions for Pal? I'm sure you can grab him during, well, maybe not during the comfort break, but maybe during the reception. Okay. Listen, thanks very much for coming. That was really helpful.
Thank you, Pete.
Okay, so we're going to have a little break till 4:10. For those of you who arrived after the housekeeping announcements, you can go to the toilet without having a pass. You just can't get back from it. So if you need to go to the toilet, then and you haven't got a pass, then just grab someone and ask to borrow their pass. In fact, why not grab Laura, who's got a hand up at the corner, and she'll take you to the toilet. Otherwise, there's tea and coffee there, which may be sort of warmish. And we'll start again at 10 past.
Anyway, thank you very much for giving me the opportunity to talk to you. At the beginning of a talk, you're supposed to give the educational objective. The objective for this one, by the end of this talk, you should be very scared. Right, now, 66 known cases of laboratory-acquired Chagas disease. That should never happen. Now, the true total is going to be much bigger because people never publish paper. Oh, we messed up in our lab and someone got T. cruzi. They're not going to publish that. So there are probably many more reports of this than are apparent. Before you get after me for the apostrophe on Chagas, I know he shouldn't have one, but that's a direct quote of Brenner's paper from 1984. Right, now, forget the life cycle you see in the textbooks. That's far too simplistic. And this one really shows you what we're up against. So, we'll begin with the vector here. Triatomine pointer, let's have a look. Doesn't, let's go back now, sorry. Previous, next, right, next, okay. So, the triatomine bug's defecating, it's on your skin, metacyclic trips go in and infect the host cells. They multiply when they're into the amastigote stage here. Now, they've invented this new stage called the zoid. I'm not quite sure whether they had to name it really, because it's just degradation product when it's transformed into amastigotes, but they did. And you have these amastigotes in the mononuclear cells multiplying, and here you can get genetic exchange, which is never shown in the infectious diseases textbooks. But this is the bit that scares me, hence my comment about dormancy. Are they going to be able to resist the drug? How metabolically active are they? And it's that stage that makes me worry about short-term treatment, not in this disease, but malaria, toxoplasma, leishmaniasis, many others where you can get a rebound later. So if I were writing a grant now, I think I'd apply to work on the quiescent phase of T. cruzi. Right, so then we're getting differentiation to trypomastigotes, and away they go into your circulation and form more nests of amastigotes as they transform, and the few trypomastigotes circulating are waiting to find a triatomine bug. In the intestine there, they're transforming eventually to epimastigotes, and again you've got genetic exchange there. So complex parasite, very, very dangerous adversary, respect it or else. So how can you get a laboratory-acquired infection? What preps are we interested in? Well, first of all, if you're dealing with triotomian bugs and you've got the infected feces of those bugs, that's how they infect us. So that's a cardinal one to avoid getting infected from. T. cruzi culture, when you multiply them up and you've got high-density cultures of T. cruzi, that's going to be significant risk. And then, okay, blood from infected humans, we're taking blood in the clinic all the time. Transfusion practice tries to avoid transfusing it, and we'll come to that in a minute. Then infected animals. And also probably can be due to aerosolized organisms. I'll come back to that. So how can it get in? Well, in healthcare, needle stick injuries shouldn't happen, but they still do. Previous skin microabrasions, in the days before Hep B vaccination, we used to get people with eczema getting Hep B with a bit of blood spilt on them because it came in through the cracked skin. And the T. cruzi, as you well know, can get across intact mucous membranes. Now, this came from the Charlotte Observer, the classical picture of a T. cruzi reduvid bug. They just show you the bug unfed. Look at this critter here. This is very sensitive mouse, this one, right? Look, well engorged, and that, by way of thank you, has defecated on the skin there. So that's pretty well gives you the impression of what's going on with the bug. And needle stick shouldn't happen, but over my career I've had many a worried doctor come to me and say I've stuck myself with a needle and the patient's got X, Y, or Z, or have they got X, Y, and Z? And that shouldn't happen, but it does. And this is interesting when aerosols. This is from studies on microplastics, people studying aerosols for asthma, for example. You can inhale microplastics and see how far they get. Well, they can get down right into the lower airways, less than 1 micron, and 1 to 5 in the upper airways. T. cruzi trypanomastigotes are up to 30 microns long. Here's a, I was going to say nice, but a fairly typical example. And they're not worried about going down here because in the upper airways, up to 30 microns are quite happy, and they'll quite happily go through your nasal mucosa or buccal mucosa or your trachea if they have to. So they can certainly get in that way. So what do we know about it? Data are quite sparse. There were 65 cases recorded, 66 now actually, and where it was known, which was only in 27, the one that bothers me is this one, no accident recognised. So they thought they were doing what they were supposed to do in their lab, but they got, remember these are ones that acquired it, they got the T. cruzi. Were they sloppy or were the precautions unsatisfactory? Parenteral, not surprisingly, 40% of them. Mucous membrane, non-intact skin. From infected bugs, that was skin contaminated by the feces of infected bugs from a xenodiagnosis type situation. The contaminated bite was interesting, a mouse bite from a negative mouse, but then was in the lab and they must have had some T. cruzi that got in the cut. And murine blood on the face. So, now what about incubation period? Vector-borne and oral are similar, 7 up to 22 if you go to the oral transmission that's quicker at the beginning. Transfusion, which I'm very interested in from another context, can be up to 120 days. With the lab acquired, it's quite quick. About 24 days is the range, so they with ease remember a significant lab exposure, most of them, but up to 28 days, and one of them even the first day, which must have been very heavy. So what does it do to you? Right, there were 26 cases where the information on the clinical presentation was known. 2 were asymptomatic, 24 symptomatic. And of that 24, there were 9 severe, and 1 died of severe myocarditis. So you go to work, there you are, working away in the T. cruzi lab, you end up dead. That's not exactly wonderful. So what specimens caused it? Infected blood in 15 of them, where the N is only 20. Trypanomastigotes from tissue culture, that's asking for it really. Metacyclic trips from the bugs, that's the natural route of infection. And 1 case, flagellates from acellular culture medium swallowed. Why? Mouth pipetting, which we now don't do. Now what strains? Now this is pre-lineage. They were named before the lineages were worked out. So I can't well, I can tell you for some of them, but it's not relevant to this, whether it's TC16 or whatever. So the Y strain, which is said to be highly virulent in mice, 6 cases. Tilhuén strain 4, Brazil strain 3. Now, CL strain is very interesting because there's more than one CL strain which messes up the literature. So the strain I'm going to talk about, isolated in 1965 from a bug in Brazil, and it's highly virulent in mice, and it was passaged, and in the beginning of 1985, almost 20 years after it came out of the bug, it was responsible for lab transmission. Somebody went down with clinical T. cruzi, having inoculated themselves with this stuff that had been in mouse passage for 20 years. Now, with some parasites, if you passage them in animals, they're going to be less virulent. But in this case, after 20 years in mice, it was still able to cause clinical disease in humans. But there are some low virulent, or they even say avirulent in inverted commas, CL strains. The point is, strain doesn't matter really. Parasite doesn't mind, it'll still infect you. So let's have a look where they knew the concentration of what they put in. This is quite scary. So somebody cut their hand with a contaminated Pasteur pipette. It had 10 to the 7, that's 10 million trypanomastigotes per mil. That's 10,000 per microliter. Put that into context. When we make a blood film, we put 3 microliters of blood on it, right? So this culture, 1 microliter, 10,000 parasites are going into you when you stab yourself. That person got 10 days of benzonidazole, 8.5 mg per kilo per day, and they got acute Chagas disease 14 days after the accident. In other words, only 4 days after they finished the course of benzonidazole. So whatever the debate about length of treatment, 10 days certainly didn't do it for this person. Clinical illness, and eventually settled down after 80 days of benzonidazole. And there was no doubt about diagnosis, xenodiagnosis and mouse inoculation. This was a true bill lab transmission. Another one. This is, it's a hot day, you're going into the lab, let's wear open-top sandals, shall we? So, somebody dropped the syringe and played darts with their foot, and it went needle down straight into their foot. And it was a Y strain with 2,000 parasites per microliter when they calculated it. And 12 days later, fever, malaise, cruralis groin, lymphadenopathy, and a chagoma at the injection site. And they did a blood smear on the person, the lab technician, and they saw trypanomastigotes. Right. This one, needle stick injury when trying to inject a mouse. I've got 4 decades of lab experience with parasites as well as my clinical work. And mouse don't want to be picked up, do they? And they certainly don't want to be injected, so they're going to move if they can. So somebody missed the mouse and stabbed themselves with 1,500 T. cruzi organisms. And not surprisingly, 16 to 18 days later, they've got a lesion on their finger, epitrochlear is elbow, and then axillary lymph nodes are up and so on. Then they get a rash. And they were negative by peripheral blood microscopy, interestingly. It was obviously still in the lymph nodes then. But hemoculture and mouse inoculation and xeno, the full house. And PCR wasn't done then, but I'm sure would have been positive. Seroconversion, day 40. So what are the key learning points? First of all, conjunctival exposure. Goggles, for heaven's sake, or a visor, or a safety cabinet, guys. Some of this, of course, was done in the days before we had good safety precautions, but you should still be scared. Working with needles, that's a high risk with many pathogens. Preparing viable parasites, tissue cultures, you're really concentrating the parasites here. Short sleeves when injecting, you should be wearing proper kit if you're dealing with animals, and mouth pipetting never happens now, but you can certainly get it. So what's the current risk? First of all, T. cruzi was not treatable until 1960, when nifurtimox arrived, Lampit made by Bayer, benzonidazole in 1972. No new drugs since, which is disgraceful. So the first lab acquisition in the 1930s was untreatable because the drug was 30 years undeveloped by then. And then even in the 2000s there was one case, but at least now we've got a chance of treating it. Various countries, various scenarios. And the literature, as I say, is sparse simply because people aren't keen to publish these kind of things. So, what do we do? Risk assessment, manage the risk and reduce it. And lab safety officers get a bad name. People think they're stopping us doing stuff. Okay, we are great supporters of lab safety officers. They keep us safe, they stop the lab being shut down, but they're not always the most popular visitors to the lab, as you will testify. Right, the Canadians classify T-cruise as hazard risk 2, and I'm not going to go through this, but, you know, closed-toe shoes is an obvious one in there. That's the precautions the Canadians would take, maybe with a safety cabinet. Right. For the UK Health and Safety Executive, I mentioned earlier I was on the ACDP for some years, and we classified it as Group 3 star. A Group 3 can cause severe human disease, may be serious hazard to employees, may strengthen the community, etc. Now, TB is the classical containment level 3 because it's airborne transmission and all the rest of it. For the ACDP, it's 3 star, which means you may not necessarily need to use all the containment of a CL3. And I'll come to that. But you'd be prudent to stick close to it. And containment level 3, you have an independent air handling system, so you can fumigate, negative pressure, double doors that you can't open both at once, and you can fumigate if you need to, and so on. And a Class 1 microbiology safety cabinet. They, in addition to the safety officer, are definitely your best friend. Right, now if things go wrong, you do not want to meet RIDOR. RIDOR is an arm of the Health and Safety Executive. On the news, over at Bank Holiday, it'll say a roller coaster carriage came off and killed someone in a theme park. HSE arrived, shut down the place, and eventually they prosecute the owners for whatever. And that's the same group that deal with RIDORs. So it's reporting of injuries, diseases, and dangerous occurrence regulations. So they say all diseases must be reported when they're attributable to an occupational exposure to a biological agent. And even if there's reasonable evidence to suggest, so if you think you've got a lab-acquired case, then you report it or else. And they can shut you down, you can end up in the court. Now, what are we going to do? All right, let's deal with now, because I get, well, over more than 30 years, I would get calls, sometimes from a schisto lab, we've just upset Sicari on ourselves, sometimes from a malaria lab, they've stabbed themselves, and sometimes from a T-cruise lab. So I've been on the end of it over the years. So Barbara Herwalt was at CDC Atlanta, and she published this over 20 years ago. I don't think it's quite what we do now, but basically what you do, monitor the person, they get symptoms, serology baseline weekly for 8 weeks or till conversion. Remember, if they work on it, they should already have got a saved serum in occupational health as a baseline. And check them for parasitemia twice weekly for at least 4 weeks. And this was pre-extensive use of PCR. In America, it's Department of State Health Services, so this is what Texas does. So if you've been exposed more than 8 weeks ago, then they do the serology, and then you get CDC to confirm it if it's positive. And then if it's under 8 weeks, you discuss with them whether you're going to do a PCR. Now, the Brazilian consensus says the following. High risk percutaneous injury, or you squirt live parasites on your mucous membranes, 10 days of primary prophylaxis. Now, we've already heard that that failed in another case, so that's what they say in their consensus. I'm not sure I agree with it. Do it immediately afterwards. That's the other problem. We're not allowed to keep a stock of them in London. We have to get it as required from WHO. So if we haven't got any in the pharmacy, they're going to have to fly it over. So immediately means when it can be airlifted over. Serology at baseline and then those times, and then treat us for acute phase if they seroconvert. They say what's minimal risk? That's contact with the blood of a chronic Chagas patient. Don't give prophylaxis, do the serology, and if they seroconvert, treat. Right, pros and cons. Chagas can kill you, yes, we know that. And treatment's more effective if started early, we know that too from the kids. But there are no randomised controlled trials, and for heaven's sake, hope there never will be on lab-acquired infection or we are in trouble. 10 days treatment will suppress, but it may not cure, as we've seen, and you're more likely to get drug toxicity, as we've already seen with the longer course, but weigh it up. Right, so what do we do? These HTD recommendations, I can't say they're hub recommendations, though we have discussed it at the MDT, because the hub doesn't have medical legal status. So if a lab exposure occurs, you'll probably end up at HTD. This is what HTD does. First of all, take a full history. the person working on this will know much more about it than you will, about what they've just inoculated themselves with. They'll know the name of the strain, what it does, its history. I know they will know that. Is it wild type? Is it lab attenuated? Is it virulent? Is it drug resistance? They are out there, and if it's resistance to both because there's cross resistance, what are you going to do then? And have they got manipulated organisms with altered surface proteins that may not be picked up by the serology? And we know there's some lineage differences. Then, what was the nature of exposure? Was it needle stick, splash? Was the skin broken or not? Was it straight in their eye? Aerosol or not? And how much was in it? That's crucial, obviously, as we've seen. And then what was the stage? Metacycline, trypamastigo, amastigo, or a mixture? Then the lab worker. You're going to need to spend an hour with that person and really go into depth. So what's your medical history? Have you worked on T. cruzi before? Have you got a baseline serum we can test compared with later? Immunocompromised, are you pregnant? Because we can't give benzodiazole or nifurtimox to a pregnant person. Are you allergic to anything? What other medication are on? You need that before you make your decision. Then what you're going to do is the recipient, PCR monthly for 3 months, then as listed there. And if they're PCR positive, do a blood film. Serology monthly for 3 months. And if they're symptomatic, whatever stage they're at, immediately blood film and serology and PCR. Now, this is a crucial bit, I think. See or discuss with a consultant parasitologist. And they are going to be anxious. Okay? We've all been on the end, some of us personally, of a needle stick, and you're going to worry. So full discussion, occupational health support, then a joint decision. HTD says prophylactic treatment 60 days, benzodiazole and nifurtimox. You just stabbed yourself with 10,000 parasites per microliter. I think you go for 60 days, I would anyway, versus observation. And if it's percutaneous injection, our threshold for giving prophylactic treatment would be low. Right, now I'm going to ask you to do some voting now. Right, here's your first scenario. Needle stick, you're in the clinic, you just sent a Chagas patient to be bled for their annual PCR and what have you, and the venicet says, oh, I've just stabbed myself with their blood. So, who's going to observe and treat if they become positive? Hands up. Right, who's going to treat straight away? Hands up. And who's going to follow another strategy? Hands up. Right, so this is right. So let's vote again. Observe and treat the recipient if they come, and you have to commit yourself because you're going to vote again in a minute. Observe and treat if they're positive. Who's going to do it? Right, okay. Who's going to treat straight away? Okay. And who's going to follow another strategy? Okay, fair enough. Right, okay. Right, now, from blood transfusion practice, we know that the likely parasitemia in donor blood from a human is less than 1 parasite per 20 ml of blood. That's 5 in 100 ml. That's 17 or so in 250 ml of packed cells. Right. So now, what do we know about giving units of infected blood to people? From recipient tracing, there aren't many. 1.7% overall got Chagas from the infected unit. But for platelets, 13%. Why? Because platelets are the Buffy-Coat fraction, which is where Debbie looks for the organisms when she's doing the PCR. Nothing for red cells, nothing for plasma and cryo. I don't think, if it's red cells only, you're not going to say there's no risk, but it just puts it into context. So we're going to vote again. Right. So who's going to observe and treat if they become positive? Yep. Who's going to treat straight away? Okay, fair enough. And who's going to follow another strategy? Okay. Do you want to share the other strategy?
Well, I guess it depends on the context. So you need to know if the patient has been treated or not, if they've got positive PCR or not, if it's just chronic infection versus, all these things.
Yeah, I agree. You get more details because it's PCR positive, all the rest of it. Yeah, excellent. Right, that's another case. Right, here we are. Feces from infected triatomine bugs spilled onto intact skin. Would you observe and treat straight away, or follow another strategy? Who's going to observe and treat? Right, okay, who's going to treat straight away? Yeah, they put the triatomine bugs straight on, feces straight on their skin and they can get through. Who's going to follow another strategy? Okay, there's no right answer to this because it's individual risk assessment. I'm just showing these to show that it's not binary, there's not machine coding here. Right, flagellate from an acellular culture medium spilled onto intact skin. Observe and treat, treat straight away, or another strategy. Who's going to observe and treat? Okay, right. Who's going to treat straight away? Okay, and who's going to follow another strategy? Yeah. Nobody knows on that one. You need to know a lot more from your laboratory as to what strain it was and, you know, the likelihood of them going through intact skin. If you ask me, I'm probably edging towards the treat zone, but you'd need a lot more thought before you decide. It's really Christina's point about finding more information. Good. Right, here we are. Needle stick with T. cruzi infected mouse blood. Observe and treat. Treat straight away or follow. Observe and treat. Right, treat straight away. Yeah. Follow another strategy. Okay. Good. Right. So conclusions. Last slide. So first of all, lab-acquired infection can result in death. We'll ignore that phone call. Is fully preventable, should be a never event. In medicine we have patient safety incidents that are preventable and so serious they should never happen again. And that should be a never event, but they still do occur. And the point is that post-exposure care is based on cumulative experiences you've just seen, not randomized controlled trials, and it really requires an MDT discussion with all the experts, especially the parasitologists who manipulate these strains and have lived with them in some cases for many decades. Thank you very much.
Thank you. Questions for Peter while we're setting mics?
I was a registrar when we had a case.
You were, yeah.
Oh, goodness me, that was a good one.
Yeah.
So in this, so if I go back to basics of the life cycle, and the parasite is aiming to look for tissue as soon as possible, right? The moment of the needle stick injury, the way I imagine is just trying to move out and get into the tissue.
Yeah.
I don't know the answer to this. How many hours would it take for that to occur? And if that is a very few hours, would we have an argument to ask Geneva to have one dose in the lab for those people just manipulating T. cruzi?
I totally agree, actually, that we need a stock of drug there in the pharmacy that can be given straight away. If after a day or so, looking at it, you say, actually, no, that isn't a risk, you can stop it. But certainly, the scenario you've just described, I think that a dose should be readily available to be given. That's my personal view. Yeah.
What was the shelf life of this medication? Because I imagine it's going to happen once in a lifetime.
Right. Okay. I mean, the point is we are treating Chagas patients anyway, and therefore having a stock, you can just tick over the stock. So you use the oldest first, don't you? And as long as it's in date, you can be using your stuff, it's still in date to treat the patients, and you still have one for the emergencies. I think that's how it would work. Yeah. Yeah.
So you're talking about 66 cases of laboratory-acquired disease, right?
Known cases, yeah.
The last one you were talking about is after 2001, right?
Yeah.
So what's your opinion? Is that because of better laboratory safety?
I'm sure it is. I'm sure it is. I mean, when I was a PhD student in the lab next door to mine, it was an amoebic lab, and we reckoned the amoebic cultures grew because the chief technician used to smoke and the ash used to drop into the cultures. People were smoking in labs then, there was mouth pipetting going on, all sorts of, and I won't say what institution, all sorts of stuff going on. And you know how safety has evolved, and I think that's a big part of it. But remember, not everywhere this is being done has the luxury of the labs we've got upstairs with containment level 3 of sophisticated nature compared to what you might find somewhere else. So I think provided you've got all the kit, it really should be very, very... The one that still worries me is the needle stick, because no matter how good your kit, at the end of the day, mice will move, and if you're not very careful, you'll end up missing the mouse. So that's the one that really scares. So minimisation of sharps, but sometimes you have to use needles.
So what is the incidence of laboratory-acquired diseases then in the last few years? I mean, I know we had a needle stick here, 2017, 2018. But anything else in the UK?
Not that we know about, no. I think it's a testament to there's a massive amount of T. cruzi work going on in this institution. It's a testament to their skill and dedication that we're not dealing with lots of this, and long may that continue. So I think it's probably very, very low risk now, but not zero. But if you go to an endemic area, you may not necessarily have the kind of stuff we've got here, and people do travel. Don't know if you did lab work on your last trip, Natalie?
Yeah, there were people with chronically infected, very highly infected mice taking blood samples with no gloves on.
Yeah.
Some pretty dodgy practice.
Yeah. So it's certainly zone related. Yeah. Thanks, Natalie.
So
yeah.
There is an attitude in certain places where they would see you as the police, and they sometimes hate the police.
Yeah.
And because I hate the police, I'm not going to do what you want me to do, and people just perhaps ignore things, and I can tell you from personal experience.
They do, but the point is that if you don't let that police look after you, a much more dangerous police person, which is called the health and safety executive, will see you in the criminal court.
The thing is, I always say, I'm not the police, I'm a scientist, and I like to see science. And
Yeah.
that might help you with doing your science.
Yeah, that's a facilitation, isn't it? Yeah.
Wonderful, thank you. We'll move on. Last question, Peter. The ones that were reported but had no apparent indiscretion in the lab.
Yeah.
You spoke a bit about aerosolization. Do you think these could have been inhalations of aerosolized cultures, or?
It is certainly possible. Sometimes, you're spinning stuff down in a centrifuge, and if it's a glass tube, it ruptures, and then you take the lid off. That can happen. Now, that shouldn't happen now because we have lidded tubes in the centrifuges and so on, and if you're doing it in containment level 3, you've got the aircon and so on. But certainly that is another factor that might be at play in some of them. They may not necessarily have cottoned on to that possibility.
Okay, yeah, thank you. So how do you follow a talk about laboratory accidents? Terrifying people. Martin, over to you.
I imagine most of you don't know who I am. So I am a molecular biologist, and I've been working on kinetoplastic diseases for 30 years, so leishmaniasis, African trypanosomiasis and Chagas, mainly on Chagas disease. And I never wear sandals. And I always anaesthetise the mice I'm going to infect, just for safety reasons. So what I'm going to tell you today is what we found out looking at mice, that what it can tell us about the potential for whether we could ever have the T. cruzi vaccine. So you've heard about all the issues with benzonidazole, the dosing, the resistance, toxicity and so on. And obviously if you could vaccinate every kid in the endemic areas and protect them, you wouldn't need that kind of stuff, assuming they're all protected. But the question is, can you vaccinate? And so the relevant points about Chagas disease are, firstly, of course, as you've heard, it's caused by infection with Trypanosoma cruzi, and so any vaccine we want is to derive protection against that specific organism. As we've also heard, and I'll mention later, it's very genetically diverse. There's several issues with this. One is the parasite can infect every nucleated cell in your body, regardless of what it is, like toxoplasma, and therefore whatever immune response you generate has to be able to penetrate and get to any infected cell. Secondly, we know in humans at least that infection appears to be lifelong if you're not treated. And for example, the girl that was first diagnosed by Carlos Chagas herself, they were still getting parasites out when she was 80. But what we also know is that in every patient there is a strong and effective immune response that eliminates at least 99.9% of the parasites, and in the chronic phase of infection they're incredibly difficult to actually find, which means that for a vaccine to actually protect you outright, it has to outperform the immune system in the infection itself. And the last one, which is probably one of the more important ones, if you're going to generate an immune response, you have to be aware that in most chronic infections, and particularly parasitic ones, it's not the parasite that causes the symptoms, it's the immune response that drives pathology. So if you're going to immunise someone against a parasitic disease, you have to know which immunity to provoke to not generate a response that could actually exacerbate the problem. Okay, so you've seen this 3 times now, so I'm not going to go through it, but basically, just to say, the stages that are exposed to the mammalian immune system are the metacyclic trypanomastigo, which is the infectious form from the bug, the intracellular A mastigote, and the bloodstream flagellated trypanomastigote. And this one, somebody's mentioned how long they take. You can infect a cell culture for 2 hours, wash them all away, and the cells will be infected. Okay, and a metacyclic can invade a cell within 20 minutes. So you don't have a lot of time to react, basically, if you have an accident. The other thing is that the metacyclics, because they're not around for a long time, you're primarily talking about innate immunity, and I'll explain that in a minute. But the ones we're really interested in terms of vaccination are the replicating in cellular form and the non-replicating disseminating form. And these are the targets of the acquired immune response. So what do I mean by these 2 terms? Well, innate immunity is what responds if you cut yourself, if you get bitten, or anything like that. It's the first line of defence. It's not specific. It can't remember a specific microbe and react to it. They just attack anything that comes in, okay? And this is primarily phagocytic cells like macrophages and neutrophils that will attack, engulf and destroy any invading organism. And various proteins within your tissue fluids and blood that are capable of latching on to organisms and destroying them, such as complement. But what we're interested in from the vaccine point of view is the acquired immune response. This takes longer to react than the innate immune response. It's specific to each microbe, and it's actually each cell in the acquired immune response is specific to one protein of the microbe. Okay. And because it's got this specificity built into it, it can be trained to remember an infection you've already had, or it can be trained for a new infection by vaccination prior to you becoming infected. And there are 2 arms of this. One is the B cells, and these produce antibodies that target microbes that live extracellularly in the bloodstream or fluids. They also target Plasmodium because that's a specific case because it doesn't infect proper cells, it infects erythrocytes, which are very different immunologically. And then there are the T cells, and there's many subtypes of T cells, and the immunologists add new ones every other week practically. But the ones we're interested in primarily are the CD8 cells, which are the killer cells, and these are the ones that will target and destroy infected cells. And we're also interested in CD4 helper T cells because they aid in generating and controlling the immune response. And the reason we know CD4 cells are particularly important as well, even though they're not actually responding directly, is that the primary target of HIV infection and AIDS is the loss of CD4 T cells. But we know there's reactivation of Chagas disease in HIV/AIDS patients. So we know CD4 T cells are involved as well. And we need both arms of this response. So we need the B cells because they can produce antibodies against the trypanosome in the bloodstream, which is extracellular. So it acts like a bacterium, essentially. But we also need these killer T cells because they recognise infected cells that have A mastigotes in, and they will attack and destroy an infected cell. Okay, so these will kill off the replicating forms, and these will stop the spread. So the question is, firstly, why use a mouse? Well, ethically you can't work on humans, obviously, especially with an incurable disease. Secondly, Chagas disease takes decades to develop in a human being. It's faster in a mouse. And thirdly, we can fit mice into imaging boxes and things quite easily. So, infected mice do develop heart disease. So this here is an uninfected animal, and this is an uninfected animal that's treated with benzonidazole. This is an infected group of animals that are not treated. And what you can see is this is a measure of heart fibrosis, which is a measure of damage to the heart. So you can see, firstly, that there are a large number of animals that have extensive fibrosis in the heart. And secondly, what you also see, as in humans, is that we have the variation. So we have some mice that don't develop any symptoms and any damage, and yet other mice get severe symptoms. And that is exactly what you see in human Chagas disease. If you treat early on in the infection with benzonidazole, you don't get the heart damage. But if you leave the treatment till the mouse has entered the chronic phase in terms of a mouse's lifespan, then you still get damage, and the benzonidazole doesn't help. And that, again, as we've heard before, is what we see in humans. Secondly, infected mice develop digestive disease, which can also be reversed by early benzonidazole treatment. So this is a control group of uninfected animals. If you infect them, this here is a measure of the time it takes food to go from the mouth to the rectum. And so when you get digestive damage, it takes up to twice as long. And again, as you see, there's a scatter, so some of the mice have barely any symptoms and some have severe symptoms. If you cure them with benzonidazole, they revert back to the normal uninfected animal. But if you have a group of mice that look like they're cured and then they relapse, you see a re-establishment of the digestive disease. So the mice can exhibit both cardiac and digestive disease that can be blocked by benzonidazole treatment. So we can use a mouse. The question is, as I said before, we can't see the parasites because there's not that many in the chronic phase. So because we're using mice, we can genetically modify the parasites. So what we do is we take the gene that makes fireflies glow and we engineer it so that instead of being green, it emits red light for technical reasons. So we have trips that then emit red light when you inject a substance into the mouse. And that means that you can actually follow the infection. So this is a single mouse infected on day 1 here. And what you see is in the first 2 weeks, the parasites are disseminating through the entire animal. And then between 2 and 3 weeks, the T-cell response starts to kick in. The parasites diminish massively. And then the disease becomes highly dynamic, and you see these rapidly changing foci. And if we were looking at this mouse by blood microscopy, this is the time frame we would actually see parasites. But with bioluminescence, we can follow a single animal for over a year and follow the course of the infection. So this black line here represents the background of an uninfected animal, and this, as you can see, is where the infection bounces around across time. And none of this part would be visible by microscopy. A lot of it would be invisible by PCR. So if you want to make a vaccine, there's several ways of doing it. One is you either use a dead or attenuated version of the organism itself. So examples like that are polio and influenza. And the issue with that, obviously, is if the attenuated one doesn't stay attenuated in some people, then you could just use a single recombinant protein that actually provokes the right immune response, like the hepatitis B vaccine. There are DNA vaccines, of which only one is licensed, which is an Indian COVID-19 vaccine called ZyCoV-D. Viral vaccines, which I'm going to talk about, which is, you'll all have heard of the AstraZeneca COVID vaccine, some of you may have had it. mRNA vaccines, like again the COVID-19, and virus-like particles like the RTSS malaria vaccine. So the one we looked at was the viral vaccine. And for this, we're actually using the AstraZeneca virus that was used for the COVID vaccine. But instead of having the spike protein of the COVID virus, it's got a gene from the surface of the A. mastigote parasite, the replicating form, and another gene from the surface of the bloodstream trypanosome. And that's for the first dose of the vaccine. For the second dose, we're using a modified vaccinia virus, and vaccinia virus is the smallpox vaccine, the cowpox virus. The reason we switch viruses is because the virus itself provokes an immune response during the first immunisation. So if you use the virus, same virus again, you get a weaker response. So you use a different virus, and you will then still get the strong response against your boosting antigen here. So when you do that, you can follow a control mouse that's not been vaccinated and a group of mice that have been vaccinated, and this heat map tells you the emission of light. So the red ones have got more parasites, blue ones have got less parasites. And what you see is that the vaccination doesn't stop infection whatsoever, but it does reduce it. So there's no red signal here. And this is a logarithmic scale, so this is 10 times higher than this, and this is 10 times higher than that. So even though it looks like they're quite close, there's actually about an 80% drop in the peak parasitemia. What you also notice is by the time you get to the chronic phase, there is no difference whatsoever. And if we look at the guts and the organs of these mice, whether they're control mice or vaccinated mice, at the chronic phase, the parasites are still established in the stomach and in the colon, and here in the lungs as well. So basically, the vaccination protects the mice against the peak acute phase, but it doesn't stop the parasites establishing. So, in order to see what actual level of protection you could get, the best way to do that is to infect an animal, cure it, and then reinfect it. Because once it's been infected and then cured, the immune response has had every target it could have thrown at it, which is the entire parasite. And so what we do here is we infect them for a number of different times, so 36 days, 14 days, or 4 days, and then we treat them with benzodiazole for 20 days, because we know the 20-day regime will cure them of this strain. And the difference is to allow the immune response to mature. So what we see is that in the ones that have been infected for 4 days before treatment, we still get a reasonable drop, so there is some immunity generated, and that's because the treatment itself takes 20 days. But in the ones that have had the longer exposure before they're treated, what we see is we can drop the peak parasitemia down by 99%. So in other words, they don't go through an acute phase. They go straight to the chronic phase, essentially. And if you reinfect with the same strain, so this is CL cure, then infect with CL, 50% of the mice never become reinfected, so you get sterile protection in 50% if you've left the infection to mature for 36 days. If you only leave it for 14 days before treatment, so the immune response is not matured as well, you only get 25% sterile protection, and that goes down. So that looks promising that there is something you could actually get that would generate sterile protection. But T. cruzi is genetically diverse, there are lots of different strains, so what happens if you use different strains? So firstly we switch to JR and reinfect with JR, which is a TC1 strain, and this is all using the 36-day challenge. And as you can see, again, you don't get an acute phase, they go straight to the chronic phase. But with this strain, which we know is more virulent in our animal models, we only get 70% protection from itself. And if we use the CL strain first and then the JR, or JR then CL, none of the animals are protected. None of them develop an acute phase, none of them get a peak, they're all trundling along in the background, but they've all gone straight to the chronic level of infection. Okay, so they're protected from acute phase, from acute myocarditis or sudden death, which we do see in some of the animal models. But they're not protected from infection, and they're not protected from the establishment of the chronic phase niche. So reinfection with a different strain, you get protection in the acute phase, but you don't get sterile protection. So why? Well, firstly, T. cruzi, as you've heard, is divided into 6 different evolutionary groups. And as you've also heard, that's still a bit controversial. But they are as genetically diverse as different species of leishmania. Okay, so we're not talking about one organism here. The surface protein genes, which are where the parasite interacts with the host most often and where the immune response reacts to most often, are all present in multiple variable copies in each cell. So the transalidase protein family, there's over 1,000 genes. The masked protein family, there's over 1,000 genes. And the mutins, there's nearly 1,000 genes. These are all different from each other. And most of the point, they're not the same genes in each group of parasites. So you might have a parasite in Colombia, it won't have the same 1,400 transalidase genes as a parasite in Bolivia. Yeah? So trying to make a vaccine that covers all of this is going to be difficult. Okay? It may be possible to create localised vaccines that are very specific to regions, but you won't be able to do it for T. cruzi as a whole, at least not easily. So the other question is, well, as I mentioned earlier, patients have a very strong immune response. They have a very strong CD8 T cell killer response, but they still remain infected for life. So what is the immune response actually doing locally around infected cells? Now the problem with the luciferase, the firefly gene, is that you can't really use it for microscopy because you need to add luciferin, you have to have ATP present and so on. So you don't get any signal with luciferase easily. So what we do for that is we take the gene from this sea creature here that makes it glow green, and we stick that into our parasites. So they suddenly turn bright green. So now we can see individual parasites. What that means is we can take a bit of bioluminescent mouse tissue, and even in this focus here, we can find a single A. mastigote sitting in an infected cell in the gut. So here you can see the villi of the gut, and this is the muscle layer where the parasite is. So we can now get to the level of detecting a single organism, and we can actually clarify what each bioluminescent focus, so this is a piece of intestine, how many parasites are actually within that. So this very bright red dot is 400 parasites in a single cell, for example. So once we've done that, we can start to ask what's going on around those infected cells. And we can stain for various markers. So CD45, for example, is a marker that stains every immune cell. So whether it's a T cell, B cell, macrophage, or whatever, it lights them all up. And what you see here is an infected cell. These long nuclei here are the muscle cells. And what you see here is a lot of little round nuclei that have infiltrated, and those are the immune cells infiltrating, and we can see them lighting up with the CD45 right around the green parasites, the infected cell. And we can stain specifically for the killer T cells and the helper T cells, and we can see that they are recruited to those sites as expected. And when we look at one of these areas where there's been a heavy infiltration of immune cells, we see that instead of getting bright green parasites, we're getting fragmented green, and the parasites have been destroyed. So the immune response is kicking off on this parasite nest and completely trashing all the organisms. So fair enough, that's what you want. But the immune response is not actually that brilliant at this, because in this piece of gut tissue, this is 200 micrometers here, this cluster of parasites, lots of the brown nuclei staining for CD4 cells, the green colour starting to get fragmented and they're dying. This one, less than 200 microns away, not a T cell in sight, they don't care, they're completely ignoring it. This one managed to attract one T cell, but it's still just surrounded by muscle cells effectively. So even in this piece of tissue here, you have 3 clusters of parasites that are very, very local to each other. 2 out of the 3 are being ignored by the T cells. 1 is getting trashed. So what does that mean functionally? Well, if you start to look at one of these big infected cells, and an infected cell can have 2,000 or 3,000 parasites in quite easily in the muscle. Okay. So these are slices through the same infected cell running up. And so you can see this cell in pieces here, and we've stained for CD45 for the immune cells, CD8, and this is just the DNA. So what you see is recruitment of the immune cells is starting towards this cell, and some of these are actually killer T cells, so this one, for example, and this one are the CD8 T cells. But what do we see going on here? The flagellated forms, the triple mastigotes, are already escaping out of the other end of the cell. So it doesn't actually matter what the T cells do to this bunch of parasites because they've already left, basically, so they can infect elsewhere. So what does this all mean? Parasite strains are very genetically diverse, so protection against one strain isn't going to protect you against another necessarily. It could do, not necessarily. Parasite surface proteins are almost all multi-gene families with high levels of variation, and there is higher levels of numbers of genes for surface antigens in T. cruzi than there are in T. brucei, which uses antigenic variation as its way of avoiding immune response. So it's actually more complicated antigenically than T. brucei is. Chagas disease patients and mice have a very good immune response but remain infected. Simple vaccination with just a couple of genes protects against the peak acute phase, but it doesn't prevent the chronic infection, at least in mice. And immune cells may actually ignore infected cells that are kind of next door to them while they're attacking another bunch. And that allows a few parasites to escape, which you only need one trypanomastigote to escape to infect another cell to start the whole thing off again. And it will take time for that new infected cell to recruit immune cells to attack it. So you can see how the cycle perpetuates over years. So, and also the other point, as I mentioned, is that we don't know enough about the pathogenesis of either digestive or cardiac Chagas disease to say exactly how we should provoke the immune response in the right way. So our feeling is that a useful prophylactic vaccine, a protective vaccine like the COVID-19 vaccine, is a while off. It may never happen. It may not be able to create one that will affect or will protect against all the geographical and genetic diversity of T. cruzi. But what may be more likely is that as we understand how these T cells are working, what they're recognising, what they're going for, how antibodies attack trypanomastigotes, is we may be able to look at a therapeutic vaccine that drives the immune response in a patient who's already infected in the right direction, drives them away from pathology and towards protection. And that may be enough to help with the chemotherapy, bring down the dose of benzoyl required because you can use the patient's own immune response. And I think in this we should be keeping an eye on what's going on in the cancer field, because in the cancer field, immunotherapy, T-cell therapy and cancer vaccines are revolutionising treatment. And they have a much more difficult problem than we do, because they're talking about targeting your own cells, specifically, tumour cells. Okay, and they're making vast leaps in immunotherapy. So we think that a protective vaccine is going to be difficult, and probably vector control is still the best way to deal with the endemic areas, as long as you maintain it. But it's possible that being able to fiddle with the immune response, that we can understand how to block pathogenesis so that even if people are infected, they don't develop disease, but also to use the immune response to attack the parasites that are left. And with that, I will just acknowledge, particularly I'll mention Gerdip, whose PhD was on the vaccine and drug cure, and Alex, whose PhD was on the T-cell stuff. Archie and Amanda are involved in developing the digestive and the cardiac models as well. Michael actually develops the bioluminescent for T. cruzi. So this is the whole T. cruzi group upstairs have been looking on this. And Bruce is the one who created the red-shifted luciferase firefly gene. Okay.
Thanks very much, Martin. Is it depressing or is it encouraging food for thought? I can't make up my mind.
Thank you. Well, beautiful stuff, you know, very sophisticated. But the thing, what kind of immunity do you see? It looks as if you saw cellular immune response rather than human when you did the studies with mice, yeah?
With the mice, primarily because we're looking at blocking the trypomastogotes from moving around is one thing, but what you really want to do is kill the amastogotes, because they're the ones that generate the massive numbers of trypomastogotes in the first place. So when we did the vaccination, also when we've done the drug cure, we look at the lymphocytes for gamma interferon production, things like that, and we know that after the vaccination, after the drug cure, we get gamma interferon producing CH1, CD4 T cells and CD8 T cells being produced.
Yeah, because it's quite two things that when you said at the beginning that the trypanosoma practically infects every nucleated cell, but at the end of the day, they seem to stay only in the cardiac and gastrointestinal.
Yeah.
So if you induce a T cell with a cytotoxic response, is that going to actually go and kill those cells?
This is one of the problems.
Be more autoimmune rather than killing the parasite.
Well, this is why you have to be careful about what antigens you have to target, because we do know that the parasite itself, the nature of some of its immune evasion is to activate polyclonal B cell activation, for example. So parasite non-specific B cells get activated, so you get antibodies being produced willy-nilly. So basically, you want to generate a response that's against the parasite, but isn't going to be against the host. But also, one of the issues is that the parasites like smooth muscle, like gut muscle, and gut muscle has a very low level expression of MHC antigens, which are required for the T cell activation. So the parasite proteins get presented on MHC molecules to the T cell. And so most of your cells express MHC, so you can actually activate T cells. But the muscle cells that the parasite chooses express lower levels of MHC than other cells in the body. So you also have to, in a way, you have to make something that is going to provoke a T cell response against the infected cell, but overcome the barrier that your own cells put in by not expressing enough of the MHC. And so one way of doing that is to try and get them to overload with specific molecules rather than the whole parasite proteome. But how we would manipulate that is...
So the other one is, you mentioned that there are some T cells that ignore the parasites of the infected cells.
Well, they're not ignoring the infected, they're attacking one, but they're ignoring the other.
Exactly. So how much chemokines could be involved in that?
That's something we're looking into now. We're kind of looking into more, because we only discovered this quite recently, so we're actually want now to look into what is the reason why some cells get attacked and destroyed and others get completely ignored, even if they're kind of next door. But we need funding to do that.
And from that point of view, I would say what they said at the beginning, I would be pessimist. First, malaria has taken decades to get a vaccine. There is no money for this, and it's a very complex parasite. I think we will certainly die without seeing a vaccine for this.
I agree with that, Mauricio. I think immunotherapy is the only way you're going to use the immune system.
Do you think I'll bring Natalie up now for the last talk. Got a question over here. Do you think the cell surface the parasite cell surface proteins are the wrong target?
Well, the problem is if you're going to hit the trypomastogotes, they're the only ones you've got to go at.
Right.
If you're going to hit the amastogote, in theory, any protein on an amastogote could be presented on the MHC, but you have to have live parasites to release the proteins to do that. So it may be that if you generate a response against an internal parasite protein, that you just attack cells that have already got dead amastogotes in them, and you ignore the living ones.
Yeah.
So we need to know more about what's actually going on at this level, at the cellular level, before we, rather than just injecting mice with an antigen and seeing what happens, we need to know what's actually going on.
Thanks so much.
It's actually along those lines, and I'll get to Martin after.
Okay, thank you. Sorry about that. Natalie. take us home. The final talk.
So, hi everyone, as we're getting up the slides, I'll just briefly introduce myself. For those of you who don't know, I'm Natalie Alkir, a medical doctor and public health specialist, and I'm 2 years into my PhD here at the school, which is mainly looking at the epidemiology of Chagas amongst Latin American migrants here in London. But I'm not going to really focus on that today. I'll just got a couple of slides at the beginning as a bit of a refresher on that kind of London perspective. But I've just recently returned from a really formative trip to both Argentina and Bolivia. And although some of that trip was also quite technical, there's been a lot of technical content in today's symposium so far, which has been fantastic. So, for example, Pau mentioned the team in Bolivia that I was based with in Cochabamba, led by Faustino Tarico, who published the Bendita trial, and they're now recruiting into Teseo. And I was also with the Nuestro Ben team in Argentina as well, that are recruiting into a clinical trial in Argentina as well. But I think that from the couple of months that I spent there, probably the most interesting kind of component of it was really just speaking to people in the street, speaking to taxi drivers, speaking to people in restaurants and shops, because people were quite interested in what I was doing there, because I went to some places where there's not a huge number of foreigners visiting, and what's this British doctor doing working on Chagas disease coming here to Cochabamba? And so I really wanted to just share some of those conversations with you today, and so I've captured a few videos just on my iPhone. I'm not Spielberg, this is nothing very technical here, but I thought did capture these specifically for this event to try and tell a few stories, really. So it's going to hopefully be some quite light relief towards the end of this symposium. So first of all, so that I can explain a little bit about how my perspective sort of shifted during this trip, I'll just set the scene with a little bit of the work that we've been doing in London. So lots of the people here are also in this room, members of our UK Chagas Hub, which is a multidisciplinary group aiming mainly to raise awareness of Chagas disease here in the UK. And the reason we want to raise awareness is because we do have a relatively large Latin American population. Not as much as colleagues in Spain, but it is still a large and quite silent population. So almost 300,000 living in England, and very heavily concentrated in London. So there are many boroughs in London where about 4 or 5% of the population were born in Chagas endemic or formerly Chagas endemic countries. And a lot of the community work that we've been doing has been focusing in these boroughs, for example, in Elephant and Castle, the beautiful Elephant and Castle depicted here. And one of the key issues that we're coming up against is this issue of underdiagnosis. So we estimated a few years ago that 97% of people with Chagas in the UK were undiagnosed. And we've been making some headway with that. We've screened about 1,000 people in the last couple of years, and we've diagnosed 80 new cases of Chagas disease and linked them into care at the Hospital for Tropical Diseases. But we do still have a long way to go. And 3 years ago now, we published this editorial in the BMJ where we talked about some of the barriers to diagnosis, why underdiagnosis is such a problem in the UK. And one of the big issues was low awareness, both of the community members themselves, but also of healthcare professionals and academics. I mean, we're all in this room because we know about Chagas and care about it, but who are the people that aren't in this room that just don't think about Chagas disease? We came across this idea that a lot of people that have migrated to the UK, although they might know about Chagas from their country of birth, they no longer think that they're still at risk having migrated and have quite low awareness of the other routes of transmission other than the vector itself. So Chagas disease is something that affects maybe my friends and family that are still in Bolivia, but not myself. Those were the kind of ideas that we came across. And all of these kind of issues are lying on top of much wider systematic issues to do with the way that people access care and the barriers that migrants face accessing what can be quite a hostile environment, as well as really difficult to access pathways for testing and referral, including what we talked about earlier with antenatal screening, a really difficult system to kind of navigate. And before I talk about Cochabamba, just as a little refresher, this is a patient called Graciela who came to speak to us about a year ago, to share her views on how difficult it was for her to get a test here in London. So some of you may have seen this video before, but after this, I promise it's all new content.
Mi nombre es Graciela, yo vengo de Bolivia, nací en Santa Cruz, un pueblito llamado Valle Grande. Ahí crecí con mis padres. El pueblo es sencillo, la gente muy sencilla. Las vinchucas es un animal muy común de ver en Bolivia, especialmente porque las casas son hechas de adobe, o sea, de barro. No es un material duro, es blando. Entonces el bicho anida en las paredes.
y cuando uno duerme sale y nos muerde, ¿no? Entonces tengo entendido que no todas son infecciosas, que algunas son que tienen el parásito, ¿no? del Chagas, pero que otras no. Pero normalmente creo que es por eso, ¿no? Es por la falta de higiene en las casas, la pobreza también. La gente no tiene la economía para hacer casas de material, de ladrillo como deben ser, y entonces la gente hace de adobe, ¿no? Entonces creo que esa es la raíz de los problemas en los pueblos pobres. En el 2002 nos mudamos a Londres buscando una mejor vida, ¿no? Y yo tuve un episodio en el 2013 de un episodio de 2 horas que me vino una como taquicardia, pero era que mi corazón latía 3 veces más de lo normal, fuerte, que al punto que mi blusa se movía. Entonces me asusté, llamamos a la ambulancia y ellos vinieron y me dijeron que me acueste en la cama, que no me mueva porque podía darme algo. Me bajaron en camilla, me llevaron al hospital aquí en College y ahí el doctor me iba a poner todos los aparatos y medicación porque el corazón ya iba muy acelerado, entonces. Pero de repente se calmó, se tranquilizó, yo estaba con un resfrío y empecé a toser muy fuerte y se calmó la taquicardia. Y de ahí me ha vuelto a venir, pero así pequeños episodios como de segundos, a veces por la noche cuando me acuesto. Yo, como le digo, he tenido sospechas cuando tenía las palpitaciones y por la historia familiar también, de que lo tenía pero he buscado aquí en el GP, le he dicho a mi doctor de cabecera que tengo este problema, puede ser esto, tengo a mi papá que tiene Chagas y ellos han buscado en el internet, pero no están muy conscientes, como que no es una enfermedad que todos lo conocen. Entonces creo que hay todavía mucho que aprender de eso. Solo fue un pinchazo en el dedo, no me dolió nada, entonces, y salió que era positiva. Pero no me asusté porque de alguna manera lo sospechaba. Entonces fue un alivio para mí poder saber que me puedo tratar y que no es algo que vaya a afectar a mi familia. Ellos también se hicieron la prueba en el mismo sitio, con la misma campaña y dieron todo negativo. O sea que yo no les transmití la enfermedad a mis hijos, o sea que fue bien. Creo que sería bueno hacer como más campañas, así como se hace para el cáncer. Ya sé que el Chagas no es el porcentaje no es tan alto como el cáncer o la diabetes, pero es una enfermedad también que está presente y tal vez sería bueno que hacer más campañas, ¿no? Como por ejemplo la televisión o la radio o los medios como el Facebook, ¿no? Así la gente puede entrar un poco más en conciencia y hacerse la prueba.
So Graciela very articulately describes just how difficult it was for her to get a test. She had tachycardia, went to King's College Hospital, a hospital which serves a really large Latin American population. She wasn't tested then. She asked her GP for a test, and the GP, I didn't know how to access the test, but either way she didn't get it there. And she also has delivered 3 children in King's College Hospital and Guy's and St Thomas's Hospital here in the UK and wasn't tested there either. And she got a test because she saw our advert on Facebook inviting her to a community event. So that's just to set the scene with the kind of London perspective. And I'd now like to go on. So that's kind of what I was dealing with in my PhD, and then had this very lucky opportunity to spend some time in Cochabamba. So for those of you who don't know, Cochabamba is in the centre of Bolivia. And as Dave mentioned earlier, what we've seen through the Chagas Clinic and through the community work that we've been doing is that the majority of our patients seem to come from this triangle between Cochabamba, Santa Cruz and Sucre. And when we see patients in clinic, we always ask people where they're from and pull up Google Maps. And we'd kind of noticed that there's this one road, so between Cochabamba and Santa Cruz, the main road passes across here, then there's a secondary road, and there's actually a tertiary road that was only recently tarmacked that passes through villages. It passes through Punata, Mizque, Aikile, and then you can either turn off and go to Sucre or you can carry on to Santa Cruz. And while I was in Cochabamba, I was looking at the map and I was thinking, I'd really like to do a road trip where all of our patients come from along this road, and it's actually that I'm going to talk to you about today. So first stop on my road trip was Mizque, which is a market town just three or 4 hours or so from Cochabamba. And there's not a huge amount going on there. Most people make their living from farming, and you can see in the quite poor resolution photo here that it's a pretty small town. It's only about 10 or 15 streets by 10 or 15 streets, but the population really swells on market days to about 20,000 when people come from the neighbouring small kind of villages. And I was there on one of the market days and circulated these photos within our hub group because they're doing there exactly what we're doing here in London, and they're offering the same rapid diagnostic tests that we're doing here. This looks a little bit different to Elephant and Castle. I think I had a bit more fun at this market day than our market days. But it was really interesting for me to see, because when we run these events in London, especially when we go to someone else's event, like we set up a stall at mother and baby groups, or we set up a stall at charity events, and we go out and we speak to people. Lots of people here in the room go out and speak to people, and the first question is usually, have you ever heard of Chagas disease? Now in Mizque, the population, you don't need to ask have you ever heard of Chagas disease. It's a very different approach, of course, because this is a town in which 80% of the older people have Chagas antibodies in their blood, and probably around 20% plus even of younger people, so even of people kind of 30 and less, also have Chagas antibodies. So it's a highly endemic area. And for this symposium today, I captured a few videos of me just speaking to people in Mizque. So I consented people, so I'd like to take a video of us just having a quick conversation about Chagas disease and use it for educational purposes. Everyone said yes and was very happy to speak. And this is the first person that I spoke to. So this is in the central plaza of Mizque. And again, they're in Spanish with English subtitles. The subtitles are a little bit rough, but I think you'll get the gist of the conversation.
¿Sabe qué es el Chagas? Una enfermedad. ¿Qué más es? Que se transmite con el de las causas los progenitores y haciendo una mamá que nace una bebé que nace su mamá igual puede nacer su Chagas. ¿Y alguna vez ha visto las pinchucas? Sí, muy alto aquí en el campo. Bastante mi mamá, por ejemplo, sufrió de Chagas, tenía Chagas de Cristina. Aquí en el campo, hasta el momento. ¿Y alguna vez se ha hecho la prueba? Yo por el momento no. Pero
So it's interesting. So the first person I speak to, her mother has Chagas disease. She's grown up with the vinchuca, with the insects, which I believe we might have someone show here a little bit later. And she's aware of congenital transmission as well, but she hasn't had a test. So that's kind of interesting, isn't it? Let's just bear that in mind. I then had a pit stop for lunch. This is in the covered market, and the lovely lady that served me a fruit bowl spoke to her as well about her experience.
¿Sabes qué es el Chagas? ¿Qué es?
Se llama un animalito. Aquí le llamamos pinchuca. Él tiene, ¿no?, ese mal de Chagas que nos pica, y eso tiene mal de Chagas.
¿Ha visto muchos pinchucos en su vida? Sí. ¿Dónde?
Hay en la plaza, donde hay galineros, en más que todo hay alta.
¿Y hay mucha gente con Chagas en esto?
Sí, creo. Sí, no estoy confirmada, pero sí hay.
She went on to say,
Sí, hay alto, ¿no?, pinchuca, y en la plaza, por ejemplo, ahí donde hay niños, hay alto pinchuca. Y de ahí viene a un cuarto, y hay veces en la noche me levanto, hay 4 bonitos, 200, ahí vienen siempre cada noche, me levanto de noche, y hay alta pinchuca.
So I was delighted to hear that the Central Plaza where my hotel was based is full of vinchucas. I think I slept with one eye open. And she later said, again, she's living with the vinchuca. She kills 1 or 2 a night. She also hadn't had a test. These tests are readily available everywhere in Mizque, by the way. And then this is in downstairs in the covered market. Spoke to a young lady again.
¿Sabes qué es el Chagas? ¿Y alguna vez ha visto este insecto? No. ¿Y alguna vez se ha hecho la prueba del Chagas? Sí, una vez sí, pero más bien salió negativo.
It's interesting, the person that hadn't seen the vinchucas has had a test and it was negative. And this obviously is not qualitative research. I'm not suggesting that ideas behind this, but you know, some ideas potentially about fear probably come into your mind, why people with the highest risk might not have a test even though they are readily available to them. And so everyone in Mizque told me you must visit the museum, which is also in the Central Plaza. That it's not huge, it's probably a little bit smaller than this room, and it's got quite a random selection of artefacts. So you can see here just some guns and some skulls and bones next to each other, and I'm not too sure what that's all about. And probably, I think here you've got some historic documents from 1597 to 1960, but the way that they're organised. And I had a chat with the man that runs the museum. So it's the type of place where you turn up and there's no one there, but someone will come and open it up for you. And so we had a chat about what I was doing there, and this is what the man that runs the museum in Mizque had to say.
¿Qué sabes sobre el Chagas?
Bueno, el Chagas es consecuencia de la vinchuca, ¿no? Que mayormente hace años las casas eran de adobe, ¿no? Entonces es donde más anidaba y se reproducía lo que es la vinchuca. Entonces desde ahí ya nuestros abuelitos, nuestras madres, muchos tienen lo que es el Chagas, y el Chagas es hereditario también, ¿no? A lo que se pasa de madre a hijo más que todo. Mediante la sangre. Por ejemplo, a mí me han diagnosticado Chagas en mi infancia, entonces hice los tratamientos correspondientes, pero aún así tengo Chagas, ¿no? Entonces tal vez no se ha logrado, no ha logrado que avance, pero se ha retirado ahí, pero hereditariamente tenemos muchos, y creo que pasa con la mayoría de la gente aquí en Mizque, en el Cono Sur, ¿no? Después el tema justamente por la herencia que hemos ido adquiriendo mediante la sangre de nuestros padres, de nuestros abuelos.
¿Y ha recibido el tratamiento?
Sí, cuando era niño, cuando tenía unos 10, 12 años al parecer. Ya lo pensé que con el tratamiento se me ha desaparecido, todavía posterior hice otros análisis, pero en el cual me han seguido detectando lo que es el Chagas, ¿no? Pero me ha dicho que tampoco ha avanzado, ¿no? Desde la última vez que me hice los análisis.
So some people talk about the idea that it just affects older people. Of course, that's not true in a place that still has some ongoing vectorial transmission, such as Mizque. And the final video that I'd like to show you from Mizque, this is one of the students who's studying hospitality and tourism that came to give me about a 2-hour tour of that museum, which is smaller than this room. And this is what she had to say. We moved the conversation on a little bit as she was telling me a bit about fear that people have of Chagas and of treatment. So we're sort of starting halfway through the conversation here. Yeah, and other conversations I had also, people also told me about different remedies that are available in the different towns and so on. And interestingly, when I went back to the city, so in Cochabamba, working in the Chagas clinic there, where they've seen an estimated 12,000 patients since that clinic was set up in 2009, and mentioned about, have you heard about some kind of treatment related to cows somehow that's available in Aikile, and they actually hadn't heard of it, and I think that there's probably not a huge amount of kind of community sensitization or whatever that's going on necessarily between the doctors in the city versus the and healthcare professionals in the city versus in the kind of highly endemic villages. I think there's probably a little bit of a communication mismatch there. And so then I headed on and visited Sucre, which is an area some of you are more likely to be familiar with. It's a very touristic part of Bolivia. And spent a little bit of time with the vector control, various aspects of the vector control program in the Chuquisaca department. So from the clinic to the entomology lab, and a little bit of time with the teams that go out and do vector control, as well as sort of healthcare education. And there's a few resources here that I will bring down for the reception in case anyone is interested. This kind of stuff is very interesting to me. I don't know if it is to you all. But just a few resources looking at kind of Chagas education and the kind of resources that have been developed for the communities from the national Chagas education programme down to a more local level as well. And that team, I don't know why these photos, there were a couple of photos here that seem to have disappeared, but there's a couple of photos that I can share from the vector control team that they sent me of what they did for World Chagas Disease Day this year, just on Sunday. And they had some large processions through the streets of Sucre where they worked with different students from the school to the university and delivering lots of education about Chagas disease. And from what I saw and what I heard from all of the conversations that I had with people is that I think teams like this have done an amazing job when it comes to education about the vector. And as you saw, some people just think Chagas, vector, it's almost interchangeable. Chagas or Vinchuca, that's almost interchangeable for a lot of the people that I spoke to. But I do think that there's a lot more that could be done in these villages in terms of the disease itself, ideas about disease progression, other routes of transmission, and as well about understanding why it is that people don't want to get a test, and see if there's anything that we can do to work with those communities and improve access to treatment and to lifelong follow-up. And then I will just end here, sorry we're a few minutes late, with the last stop on my road trip before I headed back to the city, which was in Aikile. So this little road trip was quite delayed on my trip. It's something I wanted to do right at the beginning, but I couldn't because the roads were blocked due to protests, which is quite common in Bolivia. But the roadblocks eased, and on my road trip, these were the only kind of temporary blocks that I encountered, which cleared pretty quickly. And just finally, end with a little story. So Aikile, there isn't a huge amount to see, but it's known for, you can just about make out in the background here, this is a picture of a guitar called a charango, which are traditional guitars that are made in Aikile. That's really what it's known for. But I remember having a conversation with Michael Miles and Tapan and Dave and Debbie about lineage-specific serology. That was when I was in Sucre, and I said at the end of that call that I'm a little bit disappointed that I still haven't seen the Vinchuca in its natural habitat. I've still only seen it in the entomology lab or the university lab or here. I've only seen your colonies, and I felt like I'm supposed to be becoming a Chagas expert during my PhD, and I'm feeling like a bit of a fraud. Well, careful what you wish for, because my last night in Aikile, or my only night in Aikile, I turned off the lights. There's 2 hotels in Aikile. I went for the one that had 1 review on Google, which was a 4-star review, so let's call it a 4-star hotel, and turned off the lights at night, and then I heard something, and I turned on the lights, and there was a very, very juicy Vinchuca about this big in the middle of the floor in my plastered wall hotel room. And if I'm honest with you, I did panic, and I know what you're supposed to do from my time with the vector control program, and I wish that I had the guts to collect it and take it to the team to see that if it was infected. But instead, I just threw my notebook at it, and about 5 mils of blood splattered on the floor, and I just left it there. And that notebook is still in Aikile. I just ripped up what I need. So I shall end there now after I told a very embarrassing story, and you all know that I'm a wimp. And these resources, this QR code and our social media take you to a few more resources about the work that we're doing here in London if you're interested. Thank you.
We're a bit over time, but any questions for Natalie here? Or you can take them upstairs, the reception if you prefer. Do we have some folks?
Do we have some?
We've just got some Rodneys. Luke has not given me the tritones or the dipedalogasca, but at least we've got some Rodneys.
We've got some Rodneys, so for those who are interested, not scared, some tritones there. Any questions for Natalie here, or should we take them upstairs? Let's take them upstairs. Thank you everybody for coming. Upstairs means outside the Manson Lecture Theatre, and then just follow the crowd. There's some drinks and some nibbles. Thanks very much.
Thank you.